welcome everybody to the first meeting of the joint Leicestershire, Leicester and Rutland Health Overview and Scrutiny Committee of this season. Just as it's the first meeting, I thought it'd be worthwhile us having a little quick whiz round the table of who everyone is. I'm Kevin Feltham from Leicestershire. And Brenda's next.
I'm Brenda Seaton from Leicestershire County Council.
Councillor Teresa Aldred from Leicester City Council.
I'm Melissa March from Leicester City Council.
I'm Jackie Angry from Leicester City Council, standing in for Paul Wesley, who's got a hospital appointment.
Dr Deborah Sangster, Leicester City Council.
Colin Morehouse, Head of Quality Improvement for UHL.
Good morning, John Adler, Chief Executive at UHL.
Good morning, my name's Anne-Maria Newham. I'm the Director of Nursing HPs and Quality at Leicestershire Partnership Trust.
Gail Waller, Rutland County Council. My colleague, Councillor Jeff Dale, sends his apologies.
Councillor Amanda Hack, Leicestershire County Council.
Michael Smith, I'm Manager of Health Watch in Leicester City and Leicestershire County.
Jonathan Morgan, Leicestershire County Council.
Maggie Wright, Leicestershire County Council.
Sarah Hill, Leicestershire County Council.
Patrick Kittrick, Leicester City Council, and if I can pass on apologies from Councillor Chamond, who has got work commitments.
Okay, thank you very much. I'd like to remind everyone, even though we've now just done it, that it's obviously going to be broadcast live, this on our webcast, and also it'll then be available for viewing afterwards as well. And when you do speak, please press the button, and then you get the little red light on, hopefully, and you appear on, in our case, that screen over there. The 12:30 is probably as good as much as we can spend on this, but if we can, so it's roughly half an hour per session. We'll try and move it along as we go along. So initially, then, as it states here on our minutes, I was effectively elected chair, and Patrick's been elected as nominated as vice chair. That goes as read, isn't it? Nothing we can do about that. It's done. Minutes of the previous meeting, those of us that were here, there's about 5 of us, I think. Everyone okay with that? Sign that one, please. Thank you very much. The declaration of interest. Anyone got declaration of interest? Anything on the papers today? No, thank you very much. No presentation of petitions. I've had no urgent items said to me. So on to item 6, which is the University Hospitals of Leicester 3-year quality strategy and priorities. Are you going to lead on this, John? Thanks very much.
So good morning again, everybody, and firstly, thank you for making the time to hear about our quality strategy and priorities for the next few years. I don't think I can overstate the significance of the development of this quality strategy to the Trust. Hopefully you've had a chance to look at the document that we sent around, which is not the actual formal quality strategy, which we'd be happy to share with yourselves, but the core of the content is in there, and also more detail about the priorities that we are applying the quality strategy to. The reason why this is really significant, and I hope you'll have found that the document is a straightforward read, in the sense of it's not an attempt at marketing, it's an attempt at an honest analysis of where the Trust is and where we want to get to in the future. Essentially, what we did was last year. If I rewind slightly, essentially what we have found is, although the Trust has been gradually improving over the last years in many ways, particularly in respect of the core quality of our services, which is clearly the most important thing, we have in some respects found that we've plateaued. And in Care Quality Commission speak, we've sort of plateaued at the goodish end of requires improvement, as I think members of the committee will be aware. Clearly, what we would like to be is an outstanding organisation, and therefore with good on the way to the outstanding point. And so what we did in the second half of last year was we had a really good look at what it would take to become an outstanding organisation. And actually, the way in which we did that was relatively straightforward. We looked at the characteristics of other hospitals or hospital groups that have been judged to be outstanding by the CQC. And we make no apology for that. We have deliberately tried to learn from people doing better than we are. We were supported in that, in particular, by the CQC themselves, who produced a report in the autumn of last year called Hospital Improvement, Quality Improvement in Hospital Trust, which essentially did the same thing. And you'll have seen in the documentation that the CQC identified a number of characteristics of outstanding organisations. We've also triangulated this research with what happens outside the NHS in this country and indeed in healthcare globally. And essentially, there are lots of common features. I'll come back to those key features in just a second. So in the latter part of last year and going into the start of this calendar year, we did a lot of work within the organisation to convert that research into our own quality strategy. Now, clearly, we're not starting from a zero base. A lot of what we have done has been in the right kind of territories. So many members of the committee might have heard of a number of years using listening to action as an approach to improvement, particularly valuing the input of frontline staff. We made a lot of good improvements with that, and we're very much at the forefront of that. Likewise, our quality commitment, which was our quality improvement programme around reducing mortality, reducing harm, improving patient satisfaction, actually has produced some very good results. But as I say, we feel the way we've approached things so far has reached the sort of limit of what it can do. And that was why we did what we've done, and that's why we produced the quality strategy. Now, I won't take too much time sort of talking about this. It's probably better to have a bit of discussion, but if you just indulge me for a few minutes, I'll just explain the core of it. If I could just draw your attention, I've given these out because they're a little bit easier to refer to, and you can take them away. You may well have received them in the post directly as well. If I refer you to page 7 of this document, it's also in your packs. This is essentially the quality strategy on one page. For reasons that will be obvious, we call it we've nicknamed it the COGS, and we're using this a lot to describe. So every week to our new starters, our new staff starting in the trust, I show people this amongst other things and talk through what it is we're about, because this is really at the centre of what we're doing now as an organisation, not some kind of peripheral thing. Essentially, the bottom half of this diagram is the how we're going about things, and the top half is the what we're doing. So that it's the what and the how, or the how and the what. If we start at the bottom, essentially the blue cog where it says quality improvement approach is the characteristics. It's our version of the characteristics which our research and the CQC's own work has found what it takes to be a great organisation. And just running through those very quickly. Firstly, if you look sort of top left at about sort of 2 o'clock, understanding what is happening. Hospitals in particular are very complex organisations, so you have to use data to understand what's going on in the first place rather than anecdote. Otherwise, you might start changing the wrong things or not knowing whether what you've done has made any difference. You have to be clear about what it is you're trying to improve, so clear priorities. Actually, on that, we've been pretty decent. We've had very clear priorities, certainly in my 6.5 years at the Trust, but it's the execution and sustainability of those that has been the issue. The next two, at sort of 3 o'clock and 4 o'clock, the right kind of leadership and an empowered culture are absolutely essential. They go together, as I'm sure members of the committee will appreciate. The culture is in many respects set by the leadership. So the way in which we go about leadership, particularly valuing the contribution of frontline staff and their understanding of how things can be improved, is really, really important. Because of the complexity of what we're doing, it's very important to have a consistent way of going about doing the improvement that we're trying to do, known in the jargon as a quality improvement methodology. This is where Colin in particular comes in, because he is a quality improvement expert that we've recruited specifically for this purpose, and Colin can elaborate on this in discussion if you would like. In the contrast that to what we've done so far, we've been clear about what we're trying to do, but we've really allowed people to go about it broadly in the way that they saw fit, rather than being consistent in the way we do it, and that evidence from elsewhere shows isn't the right way to do it. Particularly in the context of this meeting, working with a wider system is absolutely key. The really great places, and indeed ourselves, recognise we are only one part of the health and social care system. Therefore, to be effective, we have to understand our place in that and play a constructive part. In the bottom right-hand corner, you can see our values. Our values are one of the elements of continuity in what we're doing. Our values are actually 10 years old this year, next month. They were developed by frontline staff and patients and the public all those years ago, and we have stayed true to those ever since. And it's an important part of being consistent and having continuity in what we're doing. We use our values very actively in recruitment, in performance appraisal, in an award system, and so on there. So they're a piece of continuity, as I said. The golden sort of chain going through the middle, patient and public involvement, is, as you will obviously appreciate, absolutely key. Really great places have patients and the public that they serve at the heart of decision making. If we were to be absolutely honest about it, and being honest is a really important part of what we're doing, we have been patchy at that in the past. We've had some really good examples of doing that, but it's not consistent enough. You'll hear me using sort of words like consistent and inconsistent quite a bit, because that's a lot of what we are about here, becoming more consistent, so that we can bring everything up to the standard of the best that we do. So that is the how. The what is the pink and green cogs above, and this is a lot of this will be relatively familiar territory, because these are some of these, not all of them, are things that we've been working on for some time, and therefore are continuing a journey, but just going about it in a slightly different way. The most important in many ways is the quality priorities. These are the things that affect the core of what we are here to deliver, which is clearly care for patients. As I said, there will be some familiar items here. So take an example which is often mentioned by patients of the public: safe and timely discharge. Patients get and families get, the relatives get very fed up waiting to be discharged from hospital when they are medically fit to be. So they're waiting for drugs to take home, they're waiting for a discharge letter, they're waiting for a care package to be organised, and so on and so on. And although actually a lot of what we do is very good, particularly collaboration with local government, actually, where our metrics are extremely good, collaboration with social care, detox, and so on. There is a lot more we can do, much of which is actually internal to UHL rather than working with other agencies. So basically, you might say, well, you've been trying to work on this one, but the thing to emphasise is we're applying a different way of going about it in order to produce different results. I was involved in a meeting last week with the people leading this, really applying this new approach to our existing priorities. I won't dwell on all the other ones. I'm happy to talk about any of them in detail. The booklet, as you've noticed, expands on the detail of what we're about within all of these areas. The supporting priorities, which we have talked about in the Joint Committee, particularly around reconfiguration, of course, on previous occasions. Estate investment and reconfiguration is part of that. The development of this strategy itself is clearly part of that. Going digital, the e-hospital programme, which actually we're making really good progress with now, is a key part of that. And actually that does link in with things like working with the wider system, because if we rely on paper records, we can't share paper medical records with other agencies. Clearly they can only be in one place at one time. So that's really important from that point of view. So essentially, that is what the quality strategy is about, and how it links directly into what we are trying to achieve. What I would emphasise in conclusion, before taking questions, is that this is not absolutely about throwing the baby out with the bathwater and starting completely new. It is a progression. But it is also a more rigorous way of doing things, which learns from the best people, and therefore we are pretty confident, if we execute it well, that we will be able to produce better results for our patients and indeed for our staff. But happy to take any questions you might have.
Thanks very much, John. Maggie, you're first.
I'm just interested to know what mechanism there is for reviews and monitoring to actually really find, and I've lost my words now, sorry, I'm interested to know the mechanism for the reviews and monitorings that exist to ensure the strategy is on target and the quality is actually being achieved. I think that's what I'm trying to say. Thank you.
Perhaps I might start on that and then bring Colin in because he's an expert in measuring quality improvement as well as wider issues. We do have quite a rigorous approach, and we've made it more rigorous as part of the implementation of this strategy to tracking what is happening. We have a great deal of data available. One of the aspects of the implementation of this is actually looking at data in a different way. Sometimes the way in which we look at our data isn't actually that informative. It's not actually sort of that good practice. So we are changing all of that actually from next month, so that the way that data is presented to leadership, to the trust board and so on, and to management teams in the organisation is more informative about what is changing, what is not changing, are trends real trends or just random variation, those kinds of things. But we also supplement that with a pretty rigorous way of tracking all of these priorities and indeed a lot of other things that we're doing. So on a rolling basis at our executive board and at our board subcommittees, we are looking at all of these priorities in the pink and green cogs to see have we achieved the things we said we were going to achieve. That's where, of course, the clear priorities and plans is really important, because if you don't have a clear plan, you won't know whether you've achieved it or not. But Colin, you might want to expand on what's different about the way we're going about this now.
Certainly. Thank you, John. For us, this in some senses is also about changing the culture of the organisation to be a learning organisation, in the sense that that we know how to sustain projects. We've done lots of successful quality improvement projects, but sustainability is one of our weaknesses. And in part, that's to do with critical mass of the number of people who understand the concepts and can apply the leadership styles and the teaming styles to maintain the energy, the enthusiasm and the knowledge in the team who are actually undertaking these pieces of work. So our approach to this is to ensure that we progressively train our staff at different levels, where we'd have people that would be expert practitioners at the top and more fundamental elements differentiated amongst the workforce. And we do know from research from other areas that you have to reach a critical mass of the number of people in your organisation at any one time before this flips over and becomes business as normal. And that's our destiny. That's our point of arrival, if you like. And so what I will seek to do with my team and with others across the organisation is measure our progress towards that target. Think about it in terms of dosage or saturation. When you've got sufficient people speaking the same language, using the same approach, expressing outcomes in the same manner, then you get that commonality. And what's come from past experience with other organisations is it's the failure to have that across the organisation that makes the difference. And so that really is our ambition in terms of spreading quality improvement approach. We're using something called the Model for Improvement, which has got a pedigree created through the health systems both in the UK and America and the Northern and Southern Hemisphere, as opposed to something from industry. Industry uses quite a few techniques as well, called Lean and Six Sigma, where the emphasis is on value, and culturally we're a bit different, and therefore the Model for Improvement suits our values and doesn't jar up against our emotions when we're asking our staff to undertake quality improvement, because the values are locked in there already. I'm happy to take any other questions.
Michael.
Thank you, Chair. Firstly, I just wanted to kind of comment on Healthwatch's involvement in kind of reviewing the quality strategy. Our chair, Harsha Kotecha, sits on the governing board, and she's always kind of feeding back how kind of involved and a part of the discussion that she's been with this. And I think it's kind of interesting, the issue you mentioned around patient records is something that kind of comes up, especially when you start looking more towards the edge of the county boundaries and there's kind of multiple services involved. So that's something that's definitely a priority for patients, as well as the kind of discharge and the frustrations that patients are facing there. I was just kind of curious on a couple of things. Firstly, just about how the kind of the formation of care alliances might impact on this and how that's going to be reviewed going forward. You mentioned around the kind of quality monitoring, and some of the conversations we've had with staff members is that can actually be quite prohibitive because their priority is patient care and how that's being managed from a practicality perspective. And that kind of leads on to the final one around, you mentioned Lean and Six Sigma, and one of the primary principles of that is that it's the floor level staff that then lead that service improvement, and how you can go about empowering them to really make some changes that might be quite a little bit kind of worrisome, I think, if you looked at from above. So just curious from that.
I'll perhaps start on the care alliance and hand over to Colin about empowering the front line. For those perhaps less familiar, I'm not sure how much you've talked about in the committee or in the individual local authority scrutiny committees. We are moving towards integrated care systems, and a part of that is some kind of provider alliance or provider network. If I start immediately to sound rather vague about that, that's because we don't actually, it's very early days and we don't actually know exactly what that will look like yet. We're just at the early days of that work. But nevertheless, and this relates to the working with the wider system part of the blue GOG that I was discussing. It's very important that as far as possible we have a shared approach to quality improvement in general across the different organisations in health and social care. And there is very good news on that, because people pretty close to the front line have been asking for that. We've been naturally starting to work together. So the recent work that we did on frailty across the health and social care system very much simply put all the people who knew what was happening on the ground in a room and allowed them to come up with solutions to things. And that did succeed in breaking through quite a lot of issues which had got very bogged down. Some actually turned out to be relatively straightforward, but the traditional way of doing improvement just hadn't fixed them. I haven't got time to digress into examples of that, but it was really quite impressive. So essentially, we are going to be using broadly the same principles of quality improvement. And there is something which you may have heard about within local government circles, because it's actually particularly promoted from there, is More Good Days is one of the sort of brands around this, which is essentially more good days for patients, service users, frontline staff. It's a sort of common brand, but it uses very much these approaches. But, and we're very committed as an organisation to sort of buy into that kind of collective way of working, because it makes a big difference. But Colin, do you want to pick up about how to the quality monitoring side of things and empowering the frontline?
Thank you, John. And your question is absolutely right. It's on the money. For what will sustain the work is the degree to which the teams on the ground own the projects, and the quality improvement team and our coaching and technical skills side of it is quite a small percentage of the overall way in which this lands, the way in which it happens. So ultimately, it will be the teams at the front line who are empowered to go away and experiment and change the way in which services are delivered, and patients and other stakeholders will be a key element of that. They'll be written into the fundamental approach. And if I use the word sort of co-design and co-production, it comes more solidly into this strategy than we previously had perhaps the capability of doing. And I've been speaking to Carl Mays recently in the organisation about how do we, with a new quality strategy and our new methodology, how do we make that real? And that's also about upskilling patient representatives and other stakeholders in understanding how does quality improvement, our version of it, how is it going to work in our trust? So it's bringing them on board as upskilled partners and participants.
If I might, Chair, if I could just add to that as an example, that there's quite a degree of enthusiasm on the front line about this. Clearly it's early days, but one of the first things we've done is ask people to come forward to be what we call improvement agents. These are any frontline staff who want to be interested at any level. They've been particularly involved in the early days on working with our staff on culture and leadership, which, as I mentioned, is really important. So basically asking staff what's good and what's not good about those those areas. And we're now in the, having done a lot of diagnostic or discovery work in that territory, we're now designing what we could do differently in order to address the issues that we have. The improvement agents have been really invaluable about that. And just to give you an idea of the scale of that, we currently have 175 improvement agents, and that number is going up all the time. And these are people who are doing this role completely in addition to their day jobs. They're not getting any extra money for it. And I've done the induction of each of the groups as they come on board, and they're just a really, really enthusiastic bunch of people who want to make a difference. And I think we will see that number grow and grow, and that's how you make a really solid connection in the way that Colin was describing.
I think John actually just touched on it actually in terms, and what I wanted to know is about how colleague engagement had built this plan. I think it's really important that colleagues on the ground are able to feel that they're part of that. 175 improvement agents. Have they been enabled to do that work? My friend's a band 6, and I know how busy she is, and how extra hours that she does to make the ward run smoothly. I'd be concerned that if they're taking on this as well as all their other duties, just how supported are they to be engaged in the process?
There is, you alight upon a real tension there, and there is one. Everybody, I don't think there's anybody in our hospitals just sitting around, waiting for something to do. And there is a tension there, and there always is. The actual time requirement for ages isn't that great. It's notionally sort of a few days a month or something like that. We have done a lot of work with our line managers, our sort of middle management, if you like, about the importance of releasing improvement agents to undertake these duties. I think people get that, but the fact is you've got to maintain safe staffing levels on our wards and in all other areas, and there's an awful lot of work to do. So it would be silly to suggest that there isn't a tension there, because there is. Sometimes we use the analogy that doing all of this is almost like trying to redesign a plane while still flying it. The problem with hospitals, as you appreciate, and indeed the whole of health and social care, is you can never stop what you're doing. You can't close the factory, redesign it, and then start again. But we're very cognizant of that. We try to strike the right balance between making sure that we engage people on the ground, but being realistic about time commitment. The alternative, of course, would be to have a giant central quality improvement team who would then go along to hard-pressed frontline staff and say, we'd like you to do this, we'd like to do that, we'd like you to measure it. And although Colin will have a small core team in order to upskill people in the way that he was describing, we want to minimise that, A, because it's costly, and B, because it won't work in our kind of environment. And that is the experience from elsewhere as well.
I think you've answered most of my question, which was just about within your quality assurance methodology, ensuring there were sufficient, feedback loops and ability for grassroots staff to be able to say, hang on, this isn't good enough, or this isn't in line with where we think we're supposed to be going, or I've had a really good idea, how can I passionately and creatively put that across? Yeah, thanks.
One of the things that we realise when we start to implement these quality projects, it's never really the case that the staff don't know what they want to improve. Sometimes it's the method, it's the how, but the biggest factor that will make a difference to them owning it and enjoying doing the work of improvement, and I stress that word, because if it's not fun, it's just another job to do. And so getting the pleasure from learning that you can actually see the difference as a result of your efforts is the key thing that allows people to stay on the bus and continue to want to go down that road and sustaining quality improvement. So it's that business about ensuring that the staff are empowered to do small-scale changes that produce a result that they can see the benefit from, and that is quite addictive. It's quite encouraging for staff to keep doing that and want to keep doing that. And I think previous attempts of doing service improvement, quality improvement, have invariably been big bangs. Let's give a big bang for our buck. And the goals are too far away, and not everybody's a stakeholder in it who's doing the work. And so bringing it back to individual teams and making it fun is the best likelihood of that being successful?
If I might just add quickly on that, Chair, just to acknowledge there is a bit of a tension in doing that, because when I was introducing the strategy, I was emphasising that we're applying the strategy to these core priorities, and probably nobody would argue with the priorities per se. They're the sort of things that are important, the sort of things that concern people and are important to the organisation. But what we're really trying to combine is a sort of top down. So these are the things the organisation is focused on, with that bottom up energy that Colin was describing, because it is absolutely crucial for the reasons that he mentioned. At some point we have to bring those together. So in some way, what I mean by that is, in some ways we're happy, just as we did for many years with listening to action, to let people improve whatever they think needs to be improved, because people on the front line actually know best, quite literally, about that, because they're much closer to it than the likes of me ever will be. But on the other hand, we need to maintain focus on the things that are important overall. So it's still a bit of a work in progress, because we are in the early stages of this, about how we bring that together to harness that energy, but also stay focused. We essentially need a combination approach.
Councillor Sangster.
I do applaud the shower and bidet approach to development. Fantastic. However, on page 17, we can only sell the family silver once. Who are the partners who you intend to work alongside to sell what is the general currently, and how much do you expect to get for it? How are people going to be informed? Where are the woe moments?
So obviously the booklet includes an update on the reconfiguration plans, which is what Councillor Sang is referring to. So the answer to the question is, so if you'd indulge me just for a second, just to take the opportunity to update the committee on exactly where we are or aren't with all of those plans, because obviously we've discussed related things many times in the joint, several times in the joint committee. So where we are at the moment is that we have the work related to the interim ICU reconfiguration and all of that kind of thing. That is physically on the ground at the moment, and those service moves will take place in 2020 and 2021. In the meantime, the remainder of the plan, which would ultimately, if completed, result in the sale of part of the general site, is waiting for the next national bidding round, and that has just been pushed back to 2020. It was originally going to be in around about now as part of the comprehensive spending review, but as members of the committee will no doubt be aware, the government decided to hold a one-year interim spending review, obviously to do with the Brexit situation, and therefore pushed the main spending review back to 2020. It was quite clear once the decision to have a one-year review had been taken, there wasn't going to be a long-term capital announcement of the sort that would be interesting from our point of view. So at the moment, we're not actually bidding for to take the thing forward, because there is no process to bid into. At some point next year, something will happen, but clearly, with things being as volatile as they are now, there could be a different government, it could be anything. So it's a little bit unclear about how we go forward. But to answer the specific question, when we get to the end of that programme, which is obviously quite some years away, at that point we would, as has been stated many times, be looking to sell that part of the general hospital site that we don't need. We are, of course, in discussions with the City Council. I mean, it essentially is earmarked for housing, as you would probably expect, and we're in discussions with the planning side of the City Council about that. But it is it's not rapidly moving forward at the moment because of the national context. For complete openness, what I would also add is that many committee members may also be aware that we have been closing down the staff residences on one part of the general site because of problems with maintaining them to an adequate standard and so on. They are almost empty now. We've taken a very gradual process, but they're almost empty. Therefore, we anticipate marketing that small part of the site for sale probably at some point next year. answers the question.
There were lots of words there.
Oh, sorry.
Sorry,
Go on.
sorry.
Sorry.
There were lots of words there, and I don't think I quite understand what you've told me. I understand now that the residencies for staff are being closed down.
Yes.
Do you have partners, or is it open sale? And my question, what my starter was, you can only sell the family silver once.
Yeah.
Okay. So, who are your partners? How are you going to ensure that what actually belongs to the wider community now, because it's our NHS, so it's our land, isn't sold beyond our ability to, make use of it? So, who are your partners going to be?
To be the absolutely honest answer to that, Councillor Sangster, is that we haven't decided on what the marketing strategy for the land is yet. If you have some suggestions about how we should go about that for the benefit of the community, I'd be very happy to talk about them. We literally haven't got to that kind of detail yet.
Yeah, I mean, just on that, two things. One, you say that the bidding round will start again in 2020. Well, 2020 is a whole year. What do you envisage? Do you envisage towards the end of 2020, with realistically 2021, or is it earlier in that particular year? And in terms of the land at Leicester General Hospital, so you may not have a strategy for the development of the Leicester General Hospital site yet, but what's your marketing strategy in terms of hospital close? Because you say that's about ready for marketing.
So in terms of the timing of the capital bidding process, I don't know, because it's because there's a national government decision when they do that. Generally speaking, the cycle now is that spending rounds, comprehensive spending reviews, take place in the autumn, so perhaps September next year, as this one has been. But it's possible, post an election or something like that. It's not my area of expertise really, but it's possible that something might happen prior to that. But at the moment, we haven't been given a timetable for that. It's just been the Chancellor did talk specifically in his spending announcement a week or so ago about a capital settlement for the NHS, which would be the relevant bit for this point of view, as I'm sure you appreciate, but we have no detail on that, and there's no detail in the spending documents. So I don't know is the answer, but at the moment it would appear to be at some point next year. In terms of the, I was actually referring to hospital close specifically when I was answering Councillor Sangster's question. We have not yet determined how best to go about marketing that part of the site. We have no fixed plan. All what is known is that within the local development plan, the whole site ultimately is earmarked for housing when it becomes surplus to requirements. Obviously, much of the site will actually remain in use, but those parts which do eventually become surplus are at the moment destined to become housing because of the need for housing land.
So. Thank you, Chair. So in terms of hospital close, besides inviting Councillor Sangster to have a chat, is there any way that you're looking to engage the local community formally in that sale and disposal, or what the future of the site is? Have you got a plan for getting involved with that? And the other question I'd ask is, given that this is a big juggernaut in terms of the hospital's plan, and given that it looks like it may well get stuck in the sidings for a year or two, does that change your approach? I mean, this is a 3-year strategy, and we're about to burn through a year at least, waiting for a government decision. Does it change your approach that given that these outside factors may well just leave you hot? I don't think many people would bet against me when I could imagine that if we come back to this in 18 months' time, the hospital's planned capital bid will still be stuck in the sidings. So given that probably a centre plank of your strategy may well be just delayed due to forces beyond your control, does that change your approach in strategy?
So to answer your first question, at the moment we don't have a specific plan because we haven't really thought about how we go about it, but you make a very good point about involvement of the local community, so I will give a commitment that we will find it would be useful also to talk to your good self about, and local councillors of course, about that. So we don't have a plan at the moment, but we will need one, so just to acknowledge that point. In terms of the plan, I was on television the week before last saying that it was very frustrating, so I make no bones about the fact that these changes in the national timetable, which have happened several times in recent years, are frustrating and do make planning and making progress difficult. Of course, we have things going on at the moment, so it's not as if nothing is happening, but it is going more slowly than we would like. That is self-evident. But in terms of the quality strategy, and this is a really important point, it is quite deliberate. The previous version of something like this had the reconfiguration plans at the start and everything else after that. It is not accidental that the reconfiguration plans are now at the back and the quality strategy and our other priorities are at the front, even though they link together. And that is because, and just to be clear about that, only, I think I can say this quite certainly, the only part of the whole pink and green cog, so what we're trying to do, that is affected by what we've just been discussing is estate investment and reconfiguration, that little bit of that green cog. Everything else moves forward and is unaffected by these kind of national funding considerations. So, and that actually, it's helpful to have the opportunity to say this. That is really important within our organisation, because if we just spent our whole time focusing on a plan that just keeps getting kicked down the road, at least to a certain extent, which it has been. Then that's very bad for staff morale, and it doesn't feel like an organisation going anywhere. Actually, our new quality strategy, only a relatively small part of that is to do with reconfiguration and capital investment, and we have plenty to keep us occupied in the meantime.
Thank you very much. I do have a question, but I want to make a few comments first, if I may, please. The first is, you will have picked up from my colleagues in Leicester City that there are some concerns about the future of the trust, specifically the general site. Those concerns are also echoed in Rutland. And having sat last week through a public meeting with a large number of people there in Rutland, and having read this document as well, the one that you sent out to us, it seems to me that part of the problem, or your problem, is communication and how you communicate with the public. Now, I haven't had an opportunity to read the booklet, basically because it's not an accessible document, which I've mentioned to you. But your report that you sent to us, I have to say, is one of the best reports that I've read in the 4 years or so that I've sat on this committee. It's not only clear, but it's honest. And one of the reasons I think that the community has some concerns about the trust is that we have been subject to, for a very long time, the if I may use the term, the glossy document that often has got a lot of management speak in it, and you sort of feel it's taken off the shelf and it could be anywhere. And this document that's been produced for us this morning doesn't read like that. I also appreciate you've got a very big hill to climb. Culture change is not easy, I know. I used to work for the Audit Commission. I've done enough inspections to know it's not. But what you've written for us and what you've both said this morning reassures me that you know the direction you're going in, you know how to get there, you are employing the right amount of engagement with your own staff, or an amount. It's never right. There's always more you can do, but an amount. I wish you well, but I think the green shoots are definitely green in this respect. But, as I said at the beginning, the one bit's missing is how you communicate with the wider public. So that's just a cautionary note, if you like. My specific question, is around e-hospital. I would like you to explain to me a little bit more about what you mean by e-hospital. Is it your internal electronics, as it were, or is it us as consumers and how we interface with you?
Thank you, Councillor. Firstly, thank you for those encouraging comments. The quality strategy, the actual formal strategy is written in exactly the same way. It starts off with what is good and what is not good about what we've done so far, and therefore how we need to improve, and unashamedly how we need to, as I emphasised at the beginning, how we need to learn from others who have done better than we have. So I'm glad that comes across because it's quite deliberate. In terms of and on communication, I think the answer is you can never do enough communication in my experience, but we're certainly trying hard. On e-hospital, it's actually both of the areas that you refer to, and actually one other part as well, which I referenced briefly earlier on. So essentially, this is about going paperless. When I talk to new staff in the trust, as I mentioned earlier on, when I'm talking briefly about this, I say, if you think about your own lives, how much do you actually do with pen and paper these days? Not very much. It's all tablets, smartphones, laptops, and so on. It's all digital or paperless, whatever term you want to use. Whereas NHS hospitals, by and large, are still relying on paper records, which are hard to navigate, get lost, can only be in one place at one time, and so on and so on. So a large chunk of the e-hospital programme is literally going paperless, and we expect to get there within 3 years now. We are actually accelerating progress after quite a long time, a bit in the doldrums. You may or may not recall or have been aware, we had a plan to go big bang with a very expensive system called Cerner. It's actually an American system. It proved to be unaffordable. We then took a while to come up with Plan B, but we're now well on the way with Plan B. And we've recently signed a contract with a company called Nerve Centre, who we actually have quite a few of their systems already. And that will enable us to get it. And we can finance that largely through our own resources rather than waiting for government cash, which may or may not actually arrive. Brackets, because this is in public, we would welcome, nevertheless, any government cash that is available. I was just thinking I shouldn't say that. But anyway, more seriously, a big part of e-hospital is the patient interface. Another thing about the NHS is we are absolutely woeful in comparison to most service industries in how much information is available to patients, how you book appointments, how you can look at your test results. It is getting there, but it's quite slowly. So what you would call the patient portal end of things is an absolutely integral part of this, which will make life much easier for patients and also reduce the sort of administrative load of answering lots of phone calls and all that kind of thing. The third element, which I referenced before, is this working with the wider system. Back to that again. UHL is a sort of black hole within what is actually quite a sophisticated system in terms of record sharing, information sharing now across health and social care. We're actually quite advanced as a health and social care economy like that in comparison to other parts of the country. But there's this gap in the middle where the paper record of UHL sits. So our system partners, I actually now happen to chair the system-wide group that oversees this, is very keen for UHL to get to be paperless as soon as possible with the right integration with things like System 1 and the systems used in social care particularly. And we are making really good progress on that. I'm very pleased with where we're at on that.
Good to know. That's my background. Councillor Wright.
Very quick. I'm taking you back, unfortunately. My question's around bank staff and agency staff and how they're introduced into the quality culture, which could be very difficult because there's a big turnover. Because I know that was actually mentioned in one of the last CQC reports. So I'd just be interested in how you pick that up.
Yes, it is tricky when you have temporary staff, agency in particular. But the good news is we are actually quite a low user of agency staff within UHL. There is our regulator sets a cap which we're not supposed to go above in terms of total spend on agency. Part of that is because of the constitution. Part of it is value for money because agency staff are expensive. And we are below that cap, and the cap is actually relatively low for us because of our opening position. So we don't. We've got a good performance on that. A lot of our bank shifts are actually worked by our own staff, essentially doing overtime, and therefore that isn't so much of an issue. The biggest issue with bank staff.
Wasn't you, John.
No, I didn't touch it. One of the biggest issues we have with bank staff is moving them around. This is another tension that we have, because obviously to maintain, particularly in nursing, safe staffing levels, we move staff around quite a bit. And they don't like it for very good reason, because it takes them away from their base wards, even when they are otherwise our permanent staff. But once again, you've got things that pull in different directions there, which is sometimes a characteristic of running hospitals. But we try to treat to answer the question more directly, we try to treat bank staff as if they were our own permanent staff, and we will look to involve. We have induction and all those kinds of things where we talk about these kinds of big picture things as well.
Thank you very much. And Michael, and I've got one more, and then we must move on.
Thank you, Chair. I'm going to take you back again to just the with regards to the Glenfield site, the general site, and the kind of redevelopment. In the Naylor report from a couple of years ago, when it was talking about how you kind of have to sell estates to kind of access capital funding, it also mentioned about trying to make sure that some of the redevelopment was for staff housing. Is that something that's been fed into the plans?
Yes, indeed. We've always envisaged that in discussions with the City Council, obviously the Planning Authority, we would be talking about key worker housing, social housing, those kinds of things. So because that would clearly be an advantage in terms of recruitment, retention, and so on. So we would certainly look to have that kind of component. I won't be more specific in that, because we haven't, or I certainly haven't been involved in any more specific discussions about that. But we would certainly have those kind of things in mind, definitely.
And finally,
sorry, this comes a bit left field. Earlier this year, the City Council started a climate emergency. What in your 3-year plan are you doing towards going carbon neutral? Improving the air. I know that the Leicester Royal Infirmary is very low-lying, in a low-lying city, surrounded by traffic. And one of the things we've got about the General is it's a much less polluted site. And the growth in Leicester is going to be on that side. So what steps are you making towards accommodating the climate crisis in your forward planning?
So the Trust does have a sustainability strategy which addresses those kinds of issues, particularly with reference to our use of energy. Clearly, we're an extremely large user of energy, recycling, and the other major part of it is the supply chain, as you would expect, because we have lots of products coming from all over the place, and so on. So we do have that already in place. I think, if I was to be honest, just reflecting on your question, I think we could do with upping the profile of that. I actually get quite frequently, as you might also expect, contacted by frontline staff saying, what's the Trust doing about this? And when I get the sort of draft responses to those kind of things, there's quite a lot that we're doing. But if I was to be honest, it doesn't have a massive profile within the Trust. People aren't talking about it on a day-to-day basis. That doesn't mean nothing's happening, because there is a plan. But just thinking about it, I think we could do with increasing the profile. I think that will happen anyway. I hope I'm not talking out of school here. Andy Williams, who is the newly appointed Chief Executive of the combined CCGs, Clinical Commissioning Groups, in discussions with him, he is very keen to make sustainability and tackling climate change and so on a really big thing within the health and social care economy. He thinks we can make it a really big priority, and I think he's very genuine about that. So I think we will, when he arrives, date to be determined, but it's not that far away now. He has been appointed, just been going through the bureaucracy of it. Then I think we will see across the health, certainly the health system, and hopefully the health and social care system, an upping of the profile on that.
Yeah. And just the low-lying nature of the LRI, it is subject to a great deal of pollution. You know, currently we're trying to do something about that. Have you got any plans in place for, I don't know, greening the site in any way to provide more, like green walls, green roofs, green stuff?
Yes, I know the sort of thing you mean. Like the new medical school building has, the George Davis Centre at the university, that kind of thing. Honest answer, I don't know, but I take your point entirely that we need to be thinking about that kind of thing. I'm just being honest, I hadn't clocked that the LRI was a particularly polluted site. I could see why it would be, but it'll be something we need to give particular attention to, so I will take that back. I take your point.
Thanks, everybody. We'll draw that one to a close, but thank you very much, John, and particularly Colin. I think that's really is very useful what you're now coming up with. I look forward to the outcomes and the measurements and the KPIs, etc. I think nursing is going to be a particular issue, of course, because of the shortage of nursing nationally. So, I mean, I look forward to all that. And just on the air quality, my village is the worst in the East Midlands, and that's covered by trees and leaves. There's lots of complicated things that work on air quality. I've just had a whole load on it, but be interested to see how it goes. Yeah, look. Three commissioning groups with community services redesign, and Tamsin, you're going to take us through it.
Yes. So thanks for that introduction. Just to say a little bit about myself and my role, I'm Director of Service Redesign and Integration at West Leicestershire CCG, but I've been doing a piece of work on behalf of the three CCGs for a little over a year now, looking at our model of community health services, and particularly services that are delivered in people's home or their normal place of residence if they're in a care home. And I came to Joint Scrutiny Committee, I think in February, to brief you on the work. But the reason for coming back now is we are nearing completion of the first phase of our work and about to implement a new model of home-based care, and are thinking about the second phase of the work, and that's the purpose of coming today. So I won't spend too much time going through the aspects of how we approach the work, the methodology that we use, and the engagement, because I think that previous reports on those areas of the work have been shared with you. But I will talk more about now what are we planning to actually change and what impact we think that will have for local residents, if that's okay. So the community services redesign has been very much co-produced with LPT and social care and other stakeholders, although it has been a CCG-led piece of work. It centres on the services that are provided by Leicestershire Partnership Trust, but in no means is limited to those, and we really recognise that to improve people's experiences of community-based care, we need to work on all aspects of their care, including primary care and social care. So it has been very much a joint endeavour with colleagues across health and social care. And we have, earlier this year, set out a high-level model of the new model of care we wish to put in place, and have been working with LPT and other system partners about how we implement that model of care. So the commissioning plan supported by Leicestershire Partnership Trust Board are that as we go through to Q3 of this financial year, so in December, we will do a significant reorganisation of LPT's community teams into three blocks of care, essentially. One is to put the majority of staff, nurses and therapists, in teams that are structured around primary care networks, to really embed them in working with GP colleagues around the local populations, and to provide greater continuity of care at that local level and reduce the number of handoffs between routine care and urgent care, which was a feature of the previous model. We'll also be no longer commissioning the intensive community support service in its previous form, but commissioning instead a model that we're calling Home First, which is an integrated model of crisis response, nursing and social care for people who either are in their own homes and experiencing an acute deterioration that can be managed at home without admission to hospital, or are coming out of hospital after a stay and need some time-limited, more intensive care. So we call that kind of step-up and step-down care. And the Home First teams will be supported by integrated, shared access points called locality decision units, one in the city and one in the county, that will be teams of reablement workers, social workers, therapists and nurses who will make a joint assessment of what care package that individual needs and work to put that in place. We'll still commission community inpatient beds from community hospitals and have beds in care homes that provide more of a kind of reabling and therapy-based model of care for patients who are not so medically dependent. And those will be our three main areas of the new model of care. So as I said, LPT will be working with their staff to put those new teams in place. They're in a period of managing staff to transition into that, a lot of engagement with staff about what that means for them, and we're also working with LPT and our GP colleagues in primary care networks to try and strengthen the team building approach at the primary care network level. So those essentially are the changes that we are just about to put in place. There are some real benefits for our residents and population around that. So I've talked about increased continuity of care, but we're also moving to a much more reabling model of care, and through the work we're doing with LPT, we are able to increase the number of therapy contacts people get, and to for those people who are most in need of support to regain independence and mobility, more rapid access to therapy and a 7-day therapy model, whereas previously we've only had therapy Monday to Friday. That will be really significant to support people to retain their independence. It's not without its challenges, though, in terms of working with staff and the ways that staff have historically worked. We are also making investment into primary care networks to provide for enhanced medical cover for patients who are needing the home first support, and working with GP colleagues and LPT to ensure that there is more rapid GP response to people at home where people need support to enact a medical management plan, and trying to team build much more across hospital-based geriatricians and consultants and GP staff. So recognising that primary care will need additional resources to be able to offer the model of care we want. The anticipated impact of some of the changes will be that we expect that we can discharge more people home from hospital without having to go into an inpatient bed for a period of reablement, and that's in line with what people tell us that they want, but they've also told us that they want the support when they get home to be stronger. So that's very much part of our objectives. We will be commissioning a 2-hour or 2-day community crisis response. We determined that we wanted to do that locally before the NHS long-term plan came out earlier this year, but actually that is now a national expectation. So it really puts us very much kind of in line with what the national policy is, but we're doing that because it's what our local residents want and need. And as I said, we're also configuring community services around the future model of primary care, which again is a feature of the national long-term plan. So as we commission that new model and put investment into it, we will be evaluating what impact that has on our ability to get people home from hospital and to keep them at home through a period of crisis. The national evidence and the modelling that we have done indicates that if we're successful in that, we will have reduced occupancy of our current community-based beds, and therefore the CCGs have determined they need to reevaluate their commissioning strategy for those beds. So phase 2 of the work will be looking at the model of care at home in community hospitals and in care homes, and trying to be very clear about both the clinical model for those beds in future and the range of beds that we will need across LLR. So in doing that, we're establishing a steering group, and it has colleagues on it from Health Watch, from social care, from the local authorities, and we'll be building a significant programme of engagement with local populations into that piece of work. The work will also look at other services that are delivered from community hospital sites, because the inpatient beds on those sites are not standalone. There are some, other services there, and we need to make sure we've got a viable clinical model in all of our community hospital sites. So it's a fairly broad piece of work we're now moving on to do, and we expect it to take some months to get to a list of options for certainly the bed-based model. So I think that's probably all I wanted to say. I hope I haven't taken up too much time there.
Thanks very much, Tamsin. Anyone at the point? Yeah.
Thank you, Chair. I've got two things, one of which Councillor Wright spotted as well, which is the paragraph 33, and the risks, no additional capacity in LPT to deliver this, blah, 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 management resources and all the rest of it. That is a big red flag to me, because how are you going to get the change if they're too busy doing other things? And then the other thing is a sort of underlying issue. In the consultation stuff, there's a lot of talk about carers and families wanting to be involved, having good communications, and there's nothing I've seen in the implementation bit, nor that you've talked about how that's going to be improved. We're going to have a county-wide decision unit. How are families and carers going to get plugged into this? Because they're actually, really important in making it work. So there's two sides. How are you going to get LPT to have the capacity, and how are you involving them?
So you're absolutely right. In this financial year, there is no more funding going into LPT. So the initial set of changes will be delivered through the existing staffing that LPT has. The CCG, when they considered this model, have agreed to put some investment into LPT capacity in the following financial year, so from April of next year, and in subsequent years after that. Exactly how much we invest, we will need to confirm when we see how the current capacity can manage the demand that we experience, and we don't actually know that. So very much working alongside LPT, we agreed that we need to take a really hard look at demand and capacity in those new teams and get the learning from how the new model beds down. What LPT are able to do in the first instance, though, is to work on the productivity of the therapy teams. So there will be some additional care being delivered through more increased patient-facing time in those therapy teams. So patients will feel the benefit of that. I've been absolutely clear as I've done this piece of work that we need the right capacity in community services, and that was very much part of the business case that went to the CCG. So although there isn't any money in this year because our resources are already committed, from next April onwards there will be. The long-term plan really significantly helps on this, because there's an expectation that year on year we shift the proportion of our spend into community and primary care. In this year, we're doing that by investing in primary care. Next year, we'll begin to do the investment in community services. And in the subsequent years, we expect that to continue. But I can't confirm exactly how many resources we'll be able to put in. And partly we need to determine that question when we look at how the model operates in practice. In respect of services for carers, this work is overseen by the Integrated Community Board. The carers strategy and carers implementation plans for all the organisations in LLR feeds into that report. So there is a range of work going on through those individual action plans in terms of support for carers, training for carers, etc. We've also been really clear in describing the model of care that we want LPT to deliver. That integrated team should very much have the conversation with carers and families about what they want and what they can support their loved one in terms of home-based care, and very much thinking about how they support families and carers around ethos of kind of self-care as well. So it is built into the way we want to change the ethos of the staff and the Home First teams.
Michael.
Thank you, Chair. I'm not going to kind of gush too much about the kind of engagement that I've seen kind of throughout this programme, but I can kind of reassure the committee that there's been substantial and kind of ongoing engagement with quite a wide proportion of the community, not just people who use the services, but people that live the services, and it's been something that's been really gratifying to see. I think one of the things that I've been personally been quite pleased to see with the service design is it's taking the question of money slightly out of the equation, whereas the old system, we would hear a lot from the patients where it seems to be they got caught between health and social care and how that would allow them to come out of hospitals. This has completely taken that out of the equation, that they come out and they get the care they need without a fight between health and social care. Who's going to pay for it? It just gets the patient out, gets the care there that they need. And I think that's one of the most wonderful things, to be honest with you, if I'm being fair, that I've seen kind of come out of it. And as I say, yeah, the kind of engagement going forward is certainly something that we'll be looking to support as much as we can.
Thank you for that, Michael. And I think, that echoes my experience of the work that we've done with local authority colleagues on the Home First model and how the locality decision units will work. It is about doing the right thing for people as a team, rather than saying, well, is this a health or social care responsibility? And, we may have our disagreements behind the scenes, but that shouldn't be visible to patients and families.
Yes, Councillor.
Thank you very much, Chairman. I found this a decidedly unsatisfactory paper. I felt I understood no more from reading this than when you last came to this committee, and given that we've moved on in time, I would have hoped that I could have understood a lot more about what's happening. So I'll go through one or two of my questions, if I may, Chairman, to see if I can get any clearer at the end of that. First of all, can you explain how there is going to be more capacity in the system if the therapists are focusing on home-based activity when they could theoretically be travelling an hour or two between each client? That takes time. Or are we saying to them, your travel time is your own time, we're only counting you when you're with the person, like we do with our home care workers? Well, not we don't, but a lot of care companies do. So that's my first question. I do not see how you square the circle on that one without additional capacity. My second question is, within Rutland, we do, we have been doing for a while, quite a bit of what you're describing as Home First. It's not universal across the county, it's only in part at the moment. And so for us, I mean, given that we're lumped in with Leicestershire, in your document, which I found very unsatisfactory, it seems to me that all we're trying to do is to get access to the locality decision units and how we get the staff that are accessed through them, as opposed to the staff that are based on the primary care networks, because there obviously is one for Rutland that I'm aware of. So I'd like to understand a bit more about that. And apologies that that's a bit parochial, everybody, but we've still got 38,000 people that we need to be looking after. Finally, what happens for a patient who is not registered with a GP within the Leicester, Leicestershire and Rutland area? And we have a lot, and that isn't just a Rutland issue, that covers the whole of the county as well. If they're coming out of Peterborough Hospital or out of hospital in Coventry or something, how do they then get locked into this system when they go back home within your region?
So I'm sorry you didn't feel that the paper told you any more than when I last came. I think the key things in it are essentially that we are about to implement that model. We have agreed the investment in medical cover, which we hadn't in February when I spoke, and also the structure of the teams and how they work with primary care networks, which has moved on significantly. We also thought it's really important that we talk to the committee about the plans for looking at the bed-based model of care and what we intend to do about that, because we recognise there's going to be really significant interest in that. So that is the reason for the paper, but I'm sorry if you found it repetitive. In terms of your questions, the therapy capacity is increased, the face-to-face contacts is increased by looking at how the therapy teams work and their productivity. So it was something of a surprise, I think, to have the realisation that the average number of patient contacts for therapists in LPT was 2 a day. and so they now will be working to 5 or 6 patient-facing contacts a day. That will include their travelling time. Their travelling time is funded as part of their paid time. But there's some significant work to do with those teams and how they were working to get more patient care out of the time and a less office-based or administrative type of time. Now, LPT recognise that's a challenge, but it's something that they very much are on board with and working with staff to do. So that will inevitably lead to more patient care. So we think that's a positive, although it's a challenge.
Sorry, before you go on, could I come back on that one? That's specific. Where are these people starting from at the beginning of their day? Do they go into a base, or are they starting from their own homes?
I'm not able... No, sorry, do you want to answer that one?
Sorry.
They go from their own homes. They start from their own homes, and Tamsin's right. It was uncomfortable to look at the statistics that actually the therapists were seeing on average 2 patients a day. It was really uncomfortable. We'd put that pilot in and then we'd rolled it out, and actually that's something we do need to address. And they can see so many more patients per day. So that is where the productivity gain will be.
Sorry, I do want to press on this one. I appreciate that 2 a day is not satisfactory, far from. But unless you've got them geographically living right across Leicester, Leicestershire and Rutland, it could take an inordinate amount of time to get to your first client, let alone your other clients. And I am aware of this as a real problem because I have a friend who actually does this sort of work. It took me over an hour to get here from Rutland, and I don't live at the edge of Rutland, and this isn't exactly at the edge of Leicestershire. We are pretty central here. So if you've got a client in Colville, then a client in Uppingham, then a client in Market Harborough, how are you going to fit in 5 or 6 a day?
I don't want to comment on, how long it takes people to get to their first appointment because, everybody makes a choice of how far away from their place of work. I live in Rutland too. My travelling time is a decision when I take the job. But in terms of the journeys between patients and clients, the staff are organised around geographical hubs, so there would not be a therapist who would be expected to see a patient in Rutland and a patient in Colville. And in fact, actually, we want to group them around primary care networks. So to a large degree, we want them to be around very small groupings of GP practices, although some services, particularly in the evening, will then work across 8 hubs. But, absolutely, the intention is to maximise the patient-facing time, minimise travel and increase staff satisfaction within that while still getting good productivity out of the staff. So I hope you're reassured by that.
No, I'm not. And the reason I'm not is because there is nothing in this document that actually says these people will be based around the GP networks. In fact, it quite specifically doesn't say that. If it was, that would be slightly more reassuring. Rutland in this document is part of Leicestershire. So, even again, where are these people based for? What I imagine is not a huge number of people needing any individual therapy within a county with a population the size of Rutland, and there will be parts of Leicestershire as well, equally sparsely populated. And it's that sort of detail that I would have expected in this paper in order to give me some reassurance that this is the right direction of travel.
Well, I'd be very happy with LPT's input to provide more detail on how the teams are structured. There is a diagram in the document that does describe how the primary care network teams will work across the 3 geographical areas. In terms of the Rutland Locality Decision Unit, which you specifically asked about, we haven't lumped Rutland in with county, and we have had lots of conversations with our Rutland colleagues about how best to translate this model into Rutland, recognising the really good work that already happens around the Rutland Integrated Care Team. And we did absolutely consider constructing a single locality decision unit for Rutland. there wasn't felt to be the demand for running a specific locality decision unit for Rutland, and that was with the agreement and support of colleagues in Rutland Social Care. However, what will happen is that the access into the Rutland integrated care team will still be enabled, and direct access into that team, for instance, from Peterborough Hospital. But where a conversation needs to happen with staff that aren't directly located in that integrated care team, the county locality decision unit will have a conversation with the integrated care team about what additional resources they need and put that in place for individual patients. And we are testing those pathways out at the moment with colleagues in the Rutland team and with LPT to just check that that's adding benefit. So we're absolutely trying to get the best offer to Rutland while recognising the economies of scale around that.
And will that sort of arrangement equally apply to residents in the area in Leicestershire, for example, who are in hospital outside Leicestershire?
Absolutely. So people being discharged from Peterborough Hospital or another hospital can be served by the Home First model. If they do not have a Rutland GP, however, then the Rutland Social Care team will need to work with community nursing teams outside of LPT, because we commission LPT to manage patients that are registered with our GPs, and that is a problem for health and social care everywhere in terms of differences in responsibility for funding. But absolutely, Home First will serve people from whatever hospital they're discharged from.
So in reality then, all our residents who are living on the edges of our counties, and apologies to my colleagues in Leicester City, this is less of a problem for you. But to a number of our residents, because of where they live, in many cases can't register with a GP in our areas because there isn't the capacity. They geographically anyway are nearer to practices outside. They don't have the benefit of this, and they could still be then left in hospital forever and a day until such time as somebody finds the wherewithal to support them. Because, and the reality is, if you're a trust outside this area, you are focusing on people who live in your geographic area. You don't want to be sending people across the border.
I can assure you that hospitals across the border absolutely do want to get patients discharged and home. So we do work with discharge teams in hospitals in Peterborough, in Burton, etc. And increasingly, alongside social care colleagues, we are trying to reach out and not be so UHL-centric, but absolutely, discharge flows happen from outlying hospitals, and actually the track record in discharge from Peterborough is very good, notwithstanding that not all patients will be registered with a Rutland GP. That said, Leicestershire and Rutland Commissioning Group does only, the CCGs are only responsible for patients registered with a GP. Now, some of those people may live outside of the LLR county borders, but it's the GP registration that determines access to healthcare, as you know. But the integrated teams will work with the community nursing team relevant to that individual, and those people will get care.
Interesting. Thank you very much. Councillor Sangster, yes, you're next.
The locality decision units sound like motherhood and apple pie. How can you not think those are a good thing? We'll see the implementation, I suppose, at a later stage. And it's on the issue of seeing that my question. It's nice, good, very good, that you've done an equality impact assessment and it's been signed off. Can we see it?
I'd be very happy to share it. I don't see it at all as a confidential document, so that wouldn't be a problem.
So for us, for me at least, being able to understand how this all fits together, equalities have to be integral rather than peripheral. And so I can't really comment on this apart from it's all very nice until I understand how the equalities have been taken into consideration. Thanks.
Councillor March.
So when will we be able to see that? That was my, I'm glad that you're going to, but I want to pin you down a bit.
In terms of sharing the equalities impact assessment, the document's there, and we can share it. I will, need to fish it out, because we did it at the beginning of the piece of work, and you need to take it in that spirit that it was done at the outset of the piece of work. But I'm happy to share it.
And where there are concerns, how do we feed that through? If it's done, dusted, and finished, how do we feed through any concerns?
Directly to me would probably be the best route.
Satisfactory and unsatisfactory are such good words. I'm not sure that's helpful because it's already done. Can you see my point?
Yeah. So
Sorry, I'll stop this in a minute.
And I wouldn't see the equalities impact assessment necessarily as a one-hit thing. We've got a responsibility to look at equalities. We did an equalities impact assessment on the model at an early stage, which has been signed off as part of the business case process within the CCGs. But that doesn't mean that our concern around the equalities impact ceased at that point. It's a live and ongoing concern. And actually, as we move through to implementation, that's something that we need to be paying attention to in each of our geographies. So the locality decision unit work in the city is being led by a colleague from City Council, and is absolutely rooted in the staff that understand their patients and their populations, and they are evaluating how that's working and feeding back to us. And when we get that kind of intelligence, then we're generating additional action plans. So I don't see this as a static piece of work, and I'm very happy to share the initial assessment we did at the beginning of piece of work, as long as you recognise that that is not the final word on equalities, if that makes sense.
So when is it to be reviewed? Because it might be better then to look at the review document, because where you start is not necessarily where you end up, so it might be better to look at the review document. And when might that be?
We haven't set a date for reviewing the equalities impact assessment, so I think that's a really good challenge. I need to go away and talk to the teams about the appropriate point in time, but from my perspective it would be as we move through to implementation in December rather than before that.
And which of these bodies, sorry, I am going to stop in a minute. And which of these bodies will you be reporting back to, and when?
Yeah, so we would expect to come back to Joint Scrutiny Committee as we start both reviewing the impact of Phase 1 and the work on Phase 2. So sometime, I think actually I was asked the same question by City Health and Wellbeing Scrutiny a couple of weeks ago, and we said we'd like to come back the beginning of 2020. So if you feel that's unsatisfactory, I'm happy to have the conversation. But it's when we've got enough evidence about what the impact is to actually add to the theoretical impact assessment that we did at the planning stage. Does that make sense?
Yeah, I understand how they work. I'm just wanting to see how we can have an input and how we can see what the review looks like before I at least can say this is good or not good, because it's definitely motherhood and apple pie, isn't it? Who's going to say it's a bad thing? But we need to understand how the equalities issues are embedded. Thank you.
So it looks like there is an initial one, if you would like to see that.
From what I can understand, there's kind of no point because it's a working document. What I'm asking for specifically is when is it reviewed, when can we see the review, and then if we take what there was at the beginning and see what we've moved to, then we can see if there's any distance. We can see the journey then, can't we? But I'm trying to understand when that might be.
Well, the next meeting of this body is the 24th of January.
And
I don't know if that's too early for you.
When?
A bit close.
It is a bit tight in terms of the implementation date to get all the LPT staff into the new teams, but what I can do is have that conversation with our equality leads and LPT and say actually how rich and useful will that refresh be, or would it be better to defer it for another quarter. Can I come back to you on that?
Thanks very much. Must be Councillor March.
Thank you, Chair. Thank you, Tamsin. You mentioned about engagement with staff, and so I was interested to kind of understand what they're telling us, about how the transition is going, and particularly this move to a 7-day service therapy model, because obviously there has been quite a lot of hoo-ha, uproar in the past when we've talked about moving NHS services to 7-day ones. Thank you.
Yeah, so it's just the wrong time for my colleague from LPT to have left the room because the engagement that I've been involved in with staff was in the planning stage of the project. The management of change engagement that's now underway is being led by LPT. I am getting feedback from LPT colleagues about how that is going with staff and how staff are feeling through the change, because it's really important that we try and kind of minimise the level of discomfort really from staff going through change. I think that the feedback I've had from LPT is that the therapy staff initially expressed some concerns about challenges to the way they worked and thinking about increasing patient contacts, but are now kind of, I think, on board with that and can see the benefits of that. I don't think there have been any specific overwhelming concerns around moving to 7-day working, but I would like LPT to kind of just corroborate that. And I think in a sense, the feedback that I've had is that therapy staff were expecting this to happen, and it was a question of when they would move to 7-day working patterns to match their nursing colleagues rather than if. That said, the therapy cover will not be truly equal on Saturday and Sunday to it is Monday to Friday, although there's much more nursing work that happens on those days, and it's much more about kind of rapid assessment to meet a referral on Saturday and Sunday rather than routine scheduled therapy interventions happening on those days. So staff kind of feel they're being asked to do something that's very much needed by the patient and with a patient impact, rather than you're just working 7 days a week and there's no differentiation between those days. There have been some concerns, I think, in the staff that worked in the intensive community support service. Just be really candid, and it's in the report, in terms of they were previously seen as a very specialist team and separate from core geographically based teams working with GP practices, and they were concerned to ensure that in moving into more integrated teams they wouldn't lose their specialism, and I think LPT staff have very much been working with them to make sure that they are reassured that the skills and experiences they bring will be maintained in that new model, rather than there'll be kind of, if you like, a generic community nursing role, and that won't be the case. So there still will be staff with those specialisms about intensive clinical care for people that have got slightly higher needs. We were just talking about staff engagement on the management of change. Don't know if how much of that you caught, particularly how the therapists feel about 7-day working.
We have had to do quite a bit of work with the ICS team. The majority of them are really see this as an opportunity, but there are some of them that see this as a big change, something new, something they're not sure about. So I've already conducted 2 meetings with about 20 of them in the room. Like I said, the majority of them see this as a real opportunity, posed lots and lots of questions, really wanted to understand how it would work. We've still got 2 or 3 people that are unsure, they're not happy. And it may be that at some point we say to them, you know, is there something else or something different that you want to do? And we've just got to be more realistic about what we can do with them.
Thank you. So just to clarify, this was an open invite to all staff, and of the 20 that came, what, 10 or 15% we're talking about maybe needing to do something else with?
2.
Of 20?
Yes.
It's 10%. Yeah. Yeah. So if that's something you can extrapolate across the whole of the ICS team, then is that a reasonable assumption?
No.
Okay.
because we called it, the people that were unhappy chose to come.
Right.
And those 2 represent the majority of the people that are unhappy.
Right. Thank you.
For Amanda.
Hi, yeah, thank you. I just wanted to sort of press a little bit on the staff a bit further, if I may. You know, I did have a bit of a concern that we obviously using the capacity of existing teams, which will hopefully generate capacity because of hopefully using their time a little bit more efficiently. But then obviously in the risks, we do talk about no extra money and high vacancy rates, and how will all of those things be managed in that process? And also we've obviously the change process and staff consultation is still ongoing. When do you see an end point of that? Maybe referencing just the two that are unhappy may only be the only concern, but have other concerns been drawn through? I think the only thing that I would want to raise, and apologies if this was discussed in February, was that there had been some indication from a newspaper article with regards to the intensive community support service actually having a lot of pressure applied on them to take individuals sooner than they were ready to be discharged, this whole virtual bed model. And do you believe that this new way of approaching this will enable you to be firmer on not taking people out of hospital too soon? And that was something that was referenced in an article by James Meek about 18 months ago. There was also another point with regards to the community beds, and how does this sit alongside the wider approach to some of the community bed closures that were planned under the STP model? And has that now been thrown out of the water? Is it still happening? I'm not quite clear on where we are on the community beds, particularly. See some in Lutterworth, a sort of earmark for closure, but I know there are others also planned. So I am a bit concerned about the use of that as being integral to this plan, if there is still a horizon that these beds will be closed in the future, and how will we plan for that?
So in terms of the no more money, I'll just repeat, it's no more money for LPT this year, but the expectation is there is some for next year. That is a risk. It means that I think it limits the additional capacity that we can really provide, do what we can with LPT around productivity. This means that we're not going to see all of the benefit from the changes we want to see by March of this year, and we're eyes open about that. I see this very much, and I've always said this is a 2 to 3 year transformation piece of work. The investment needs to go in to support that. We, at the moment, are not saying that we're going to significantly increase the number of patients other than therapy contacts in this year, but the ambition is that we can do that next year, which I think then sort of takes me on to your second question about safe discharges and discharging people at the right time, not too soon, not too late. That has been a concern, I think, for some clinicians, GPs and ICS staff at times. Equally, there's a lot of concern about patients not being able to be discharged when they are ready, and we need to get that right. So part of the reason for prioritising the funding of the medical cover is to enable us to make a better, safer discharge with more medical oversight in the community. One of the drawbacks of the ICS model is those nursing staff, and there were some ANPs that had oversight, but actually they didn't have kind of direct line to funded medical cover for the patients they were looking after, and that exposed the teams really at times to looking after potentially quite unwell patients or patients that might deteriorate without the level of medical cover that we think they should have. So that's one of the priorities for us to put right, and that's why that's the first bit of investment that's going in this year. And yesterday I was sitting down with LPT and UHL colleagues to talk about how can we get better discharges, how can we improve the clinical confidence that the discharge is right, both from the hospital perspective but also from the receiving community team perspective. So we're going to have to test out how that goes, and I'm not saying we'll necessarily get it right on day one, but there is a much better kind of system oversight of the need to do that, I think, than there has been over the last couple of years. Going on to the position on the community bed model, I think what I would say is that the previous Better Care Together plans around the number of community hospital beds we need are sort of dead in the water, if you like. What we've said is actually we don't know that they're the right numbers, and part of the reasons for doing this piece of work is to say actually what's the clinical model and evidence base about what is the right number for the future. We still don't know that, and that's the second piece of work that I've described moving on to. And I'm not going to overrush that. We want to do that properly in the light of how we see the Home First and the new community team model bed down. But as we go through into 2020, I think we will be starting to make some, to develop some options really about what the bed model looks like in future, and we will be coming back to talk to you about that, and we will be engaging with the local population as we start to generate potential options.
Ms. Tomlin, finally, yes.
Hello, yeah. Again, it seems when you were discussing with Miss Waller, there's going to be a lot of practitioners on the road all over the place. And I wondered what thought had gone into that in terms of what they're going to be travelling in. I know this Leicester City Council have a community crisis, not a community, a climate crisis. So are you going to be buying what they're travelling in? Are you going to be aware of the climate impact of the vehicles they're going to be in? I know we're going to do a workplace levy, so things about parking and stuff like that. I know it's nothing to do with nursing, but it does seem to be an awful lot more people on the road with this than gathering patients in one place.
Yeah, we absolutely get that. So in terms of how we can minimise travel, but recognising that when people are in their own home and housebound, they can't necessarily come out to receive care. How we can minimise that, I guess there are a number of things. There is something called the Health and Social Care Protocol that we currently operate between health and social care, which aims that, you know, whichever healthcare professional or social care worker is in someone's home can undertake tasks on behalf of the other agency to minimise two individual people having to go out. That reduces travel that has to happen to patients' home, and we're currently reviewing that. We're talking in each of the 3 local authority areas about the potential to develop a shared workforce that enables us to do more about joint tasks rather than having to have more than one professional attend someone's home, and that can minimise travel. I'm not, the CCGs are not responsible for buying vehicles, so I'll have to ask Anne-Marie to comment on the provision of vehicles to LPT staff, but there are things that we are doing with care homes at the moment to put in place telemedicine and Skype type consultations between the care home staff and doctors to avoid a need to go out and attend the care home. If those prove successful, we could look at rolling those out to individuals in their own home. That would obviously have IT implications around, you know, people having iPads or laptops that had Skype enabled, but at the moment we're testing that with care homes, and so far that seems to be really positively received and having good clinical outcomes.
Did you want me to comment on the cars? So there's a mixed. Sorry. There's a mixed economy of what staff choose. It's their choice. So they can use their own cars or they can take a lease car. And they're remunerated through the petrol and diesel. They claim their expenses back.
Patrick, you had some.
Just for the benefit of Councillor Nangreve, it's a case of when we discussed this at the City Scrutiny Committee, I agreed as chair to do a task and finish group around home visits and particular challenges around, as you will know from your ward of Westcote, the vast majority is in the residents' parking scheme. Therefore, that does present challenges for visitors who are delivering care, and it is envisaged that we get a task and finish group together to look at these issues and how things might be organised differently. Certainly, as a councillor for Westcote's ward, I'm sure you'd be quite interested in being involved in that, and we'll copy you into any communications around how we look at that.
Thank you. I'm still very concerned that, you know, we've got 12 years to the end of the world or something like that, that we're still remunerating people on their own cars instead of thinking about the most efficient forms of travel we possibly could have at this late stage in the game. You know, I think, you know, we're saying that, you know, you can have your own car and we'll pay you back worries me.
Sadly, I don't think there's much we can decide that as an institution. I mean, it's a national thing, isn't it? Right, thank you very much. Oh, sorry.
Thank you, Chairman. I've just got one question, and it's about Pathway 3. Where are the actual residential homes that will be part of this programme, please?
So they are in a number of locations. So we have one block contracted facility that is on the outskirts of the city, commissioned from Sovereign Care Homes. We also have, I think, the number now is 10, but I would need to check, care homes that are commissioned within a framework, but essentially spot purchased beds that are in various locations around the county. I'm not sure if we actually have any home on the framework in Rutland, but actually Rutland is using fewer and fewer of those beds because of their successes around keeping people at home with the integrated care team, and that's something we want to see if we can replicate across the county. So I can provide you with details of the locations of all of them, but I just don't have them in my head, I'm afraid.
Okay, thanks. I mean, the only query I had, actually, to be fair, from the whole paper was actually on our page 47, where you've got a list of the operational delivery model, community planned nursing, therapy and home first services. And if I'm right, there seem to be 10 planned care nursing teams for West Leicestershire, 10 planned care nursing teams for Leicester City, but only 7 for East Leicestershire and Rutland. I'm just intrigued that populations of East Leicestershire and Rutland is larger than West Leicestershire.
I don't think that is correct in terms of GP registration, actually. I think it's the other way round. But those teams are designed to mirror the configuration of the primary care networks. So we've got 7 primary care networks in the east and 10 in the west. They all vary between 30 and 50,000, but I think East's registered patient list is smaller than West.
Thank you very much, that's helpful. Right, thanks very much, Tamsin. We'll move on to the next page, which is action 8, which is, if I get it right, page 51 in the packs, which is a report of Leicester, Leicestershire and Rutland clinical commissioning groups, this time planned care update. And I think we've got Ked Chudam Sama and Helen Mather, I believe, giving us a talk. I'll let you introduce whichever bit of it you want to start with.
Thank you, Chair, and thank you for the committee for hearing about our update this morning. My name is Ketchu Dasama. I'm the Director of Performance and Corporate Affairs at West Leicestershire CCG. I'm also the Joint SRO for Planned Care across LLR.
I'm Helen Mather. I'm the Planned Are we all right? So I'm the Planned Care Implementation Lead, but also I'm the Director of the Alliance, which is the community hospitals, elective care, so outpatient and day case services across the 7 community hospitals. I've got 43 years experience in the NHS and I'm a nurse, but I did spend 30 years in acute care, so I'm used to delivering services in hospitals. And I look quite good on the basis of having gone through all of that, I think.
Okay, thank you. I haven't quite got 43 years on Helen yet, but we never know. If I just give you, if I start with maybe just a little bit of context, and then just really go into a couple of the major headlines of this paper, which are around an update on the referral support services, and secondly, an emerging direction of travel on our outpatient transformation, which is at a very early stage. So that's the purpose of bringing that to yourselves. So just by way of context, I'm sure you'll know that demand for outpatient services continues to grow at a very fast rate, which on a pressurised hospital services sector compounds a problem, which means that hospitals struggle to cope with the demand, the capacity, and also the staffing. What that means is that patients wait longer, and there's more patients waiting. Just to give you maybe a sense of the scale of the numbers, LLR CCGs spent just over about £227 million on planned care last year. 2/3 of that is actually spent on operations, and 1/3 of that is spent on outpatients. And for those outpatients, we have about 500,000 actually of follow-up outpatients, and we spend £36 million on follow-up outpatients. And I'll talk a little bit more about that as part of our transformation of outpatient services later. But I just thought it's useful to just give you, some ballpark numbers about the scale that we have across all of our providers, not just UHL. The paper that you've got in your pack refers to two strategies, two strategy stroke papers. One's around the RCP paper, which talks about the very traditional outpatient model that we've had in the NHS since its inception over 70 years ago. That hasn't changed. And they're saying that it's not fit for purpose and it needs to be much more patient-centric than it is now. The second paper is around the long-term plan, and specifically the commitments within the long-term plan are about reducing 1/3 of what they term unnecessary face-to-face consultations over the next 5 years. I think we need to go further than that, in fairness, to create the type of service that we really need. You'll be pleased to say we're not starting from scratch. We've actually been working as a planned care workstream under the Better Care Together banner for a number of years now. We've been working closely with our system partners, and in particular UHL, on those projects. One of the major projects that we've had during this financial year has been the referral support services, and that's included in your paper here. And in summary, it's going really well. We've had 3 specialties that have come online since April this year, and we've got ophthalmology and general surgery, which are due to go live fairly soon. Referral support services is essentially about directing patient referrals to the most appropriate service and location. So, for instance, we've had one for MSK that's been operating since April, and I've got actually data which is maybe a little bit more recent than what you've got in your packs. So April to August data, we've had over 12,000 referrals for MSK have actually gone into this referral support services service, and as a result, 2/3 of those patients have ended up in a hospital. We've had 10% which have gone back to general practice with advice, and that's just over 1,200 patients, where ordinarily these patients may have gone into hospital for an appointment. But as part of this service, the advice that's gone back from experienced GPs who were trained and accredited has said there's no appointment that's actually required, and they've advised the GP of better treatment and management for those individual patients. And for MSK patients, we've actually treated over 20% in primary and community care. Again, that's 2,500 patients who potentially could have gone into a hospital, but instead will have been treated in primary and community care. That's just MSK. Just very quickly, dermatology. Since it started during the financial year, we've had nearly 3,500 referrals. In fact, only just over half of those patients have ended up in hospital. 12% have gone back to GPs with advice, and over 20% have actually specifically been treated in primary care. So again, I thought useful to just give you a flavour of some of those examples, just to indicate how we're actually beginning to move some of the care much more closer to home, and one of our aspirations is to continue to do so. The feedback from referral support services from patients has been very favourable, and also from the hospital departments themselves. They've noticed a reduction in the volume of patients going in, which has been positive to help them to cope with some of the capacity issues and the pressures that they face. We're also now at a stage where we're going to be planning stage 2, and we've got a list of specialties which we're considering what goes live next. So that's kind of where we are with referral support services. The second major area really is to talk to you about transforming outpatients. I mentioned at the start there was a couple of papers, whether it's the RCP paper or the long-term plan, which says things need to change. They've been the same for the last 70 years, and we need to be much more radical in our transformation. There's a diagram that's been included in paragraph 26, which hopefully people have had the chance to look at. And you'll notice it is at a very early formative stage. It's not particularly polished. It just gives you a sense of where over the last month or so some of our discussions have got us to around some of the key areas that we need to focus on as part of our transformation. And principally they're across 4 areas. The first around prevention, and this is something that's not kind of solely within the gift of plan care, as people around the table would recognise. It's working much more closely with a great number of agencies, and some of those are included within there about improving lifestyle choices and behaviours and access to weight management, lifestyle and healthy eating, schools, from a whole range of areas, and also technology. Technology features quite heavily in where we need to get to with some of our prevention work. It's interesting, and Plan Care will need to tap into that and work closely with those agencies. It's interesting when we've done a lot of our engagement work on Plan Care over the past few years, what we've found is some of the insights from patients with long-term conditions. These patients have said we want to look after ourselves, but we want access to support when it's required, and it's making sure that we can find a way of facilitating that effectively. So that's the first block. As I said, it's not something that's wholly within the gift of ourselves, and it requires multi-agency working to enable our offers and aims to be achieved over the next 5 years. The second one is around essentially managing the demand in the inflow that goes into hospitals, and we've got referral support services, which is one of those areas. What we want to do is we want to expand the range of specialties that we have referral support services for, and also we want to be able to expand the range of services available in primary community care to look after and treat our patients. And Helen, hopefully during the Q&A, may be able to give you some further examples of what this could start to look like. The third section from the left is around improvement management of referred patients. So once they're in hospital, what happens, and making sure that that experience is as good as it possibly can be. And we know that the Trust, although we've got no Trust representatives with us today, we know that the Trust has done a lot of work on both outpatient and theatre transformation to improve their efficiencies and optimise how clinics are run and optimise how theatres run effectively. It's a shame one of the colleagues has just left because I've got the words about carbon net neutrality ringing in my head. And if I can indulge you for a moment, one of the elements of insight we get from patients and carers has been when people have follow-up appointments, and I mentioned that at the start in my opening context, we have 500,000 of these a year. Patients or carers end up having to take half a day off work. They're either on public transport or they're driving their way into a hospital, whether it's Peterborough, whether it's UHL, whether it's George Eliot, wherever. It's not great for the environment. What tends to happen is once they're seen in outpatient clinic, it's probably usually late. It probably doesn't last very long, and they probably don't maybe have enough opportunities to ask the questions that they would have wanted to ask before they embarked on their journey. Let alone, I don't know whether the world will end in 12 years' time, but all of that petrol consumption and harm to the environment, we need to find a way of absolutely making significant changes to that. I nearly said inroads, I mean changes to that. So then the final area on the right-hand side is around what happens when the ongoing care and the discharge of these patients, and particularly around follow-ups. This is an area where we've really got to see the bulk of our change. And the paper talks about some of the early questions when we've sat down with some of our clinicians and some of our patients on our Plan Care board around how we tackle this. So really we need to start asking, is a further follow-up actually required? We know clinicians, and particularly more junior clinicians, are risk averse, and as a result it's less risky to see the patient again in 3 months or 6 months' time, but it's often repeats that cycle that I just described. So we need to be much more braver about where follow-ups are required and where they're not. Interestingly, there's a question about, can the patient self-manage? I mentioned, patients know how to look after themselves. And often it's knowing who to go to and what advice to require when things don't go well. Is virtual management possible? So how can we use some of our technology and working differently? So for instance, there's an example in the paper, there's the arthroscopy, arthroplasty service, that we've got running, which is called the LARC, that takes place in UHL, which for hip and knee operation patients ordinarily would have been seen at least once between 6 to 12 months after their surgery. Now they complete a co-design questionnaire which they've worked with the clinicians on. To complete that, those are sent in and those questionnaires are then reviewed by the clinicians virtually. At that point they decide based on a number of clinical markers whether the patient should be seen. Interestingly, only 1% of patients are invited back and require seeing a clinician physically in the hospital. So we're doing it in pockets. Problem is it's pretty patchy. It's not happening in a systematic way, and we've got some examples of how we can do it well, and the patient experience scores are fantastic in that area as reported back from the lead clinicians, but we need to do that more consistently. And then finally, follow-ups are required, but they don't require a consultant to do them, and they don't require travelling into a big hospital in the middle of town somewhere. They can be done in local GP practices and community hospitals in other settings by specialist nurses, by optoms, and we're seeing increasingly more work that can be undertaken by the wider clinical staffing base. What we want to do going forwards is to get more thoughts about this type of direction, and part of that is really hearing some of your initial reactions to this. But then secondly, having a workshop for a couple of the specialties where we'd like to take this forward, making sure that we've got patient and carer representatives there together with clinical and staff representatives about how this could start to look, and then we can move forward. But we didn't want to do anything too fast too soon in coming up with this is what the final model looks like. It's going to need to be pretty iterative, and I suspect it will be different for different specialties. But that's what we want to be doing over the next couple of months. So I may just pause there for questions from yourselves, and myself and Helen will try our best to answer those. Thank you.
Amanda.
I'm not 100% sure if this is the right place to ask the question, so I'll ask it, and if it's not the right place, you can tell me off. We obviously had a report in the Mercury yesterday about the removal of X-ray services out of Hinckley. What impact will that have on the MSK seeing it in the community? And I'm assuming it will have an impact. Probably is maybe the right place to put this. And I suppose the other thing is my own experience. My daughter has multiple allergies. She's seen by dermatology and dietitian. I live in Braunston Town, which is probably walking distance to Braunston Health and Social Care Centre, but I can't see the dermatology nurse there. I have to come into the Royal. What is actually being done to break that down? And I'm hoping this is part of this process.
Right, so first about Hinckley and the imaging. So the piece of kit we're talking about is 27 years old. It's part and parcel of the new Hinckley build we were hoping it would survive until we got the new build. That has not happened. The big problem is we had problems earlier on in the year. We managed to salvage kit from elsewhere within the world, not just this country, that kept it going. However, it's literally the X-ray tube is actually on a plinth at the very top, and it's held by, and I'm no technical person, but it's sort of like locks and ball bearings, and what they're doing is they're seizing. So when a radiographer goes to do an X-ray of either your chest, or it's normally a limb as well, and we do about 1,000 of those for outpatients a year and about 10,000 for the GPs. It's locking, and it's actually endangering the staff from a musculoskeletal point of view. So that's why we've come out and said we cannot continue. So what we're doing at the moment is, so what other options could we do? Can we bring the money forward from the build, the new build, and try and get that done quicker? That's one option that we're pursuing. Is there anything that's mobile? Because you can get it's very funny because you can get mobile CT scans and various things like that, but mobile plain film, which is your most basic imaging, it's not that easy to get your hands on a mobile machine, but we are looking at that as we speak. So the plan is that we will do that. So in the meantime, we do have, because we've got imaging at most of the community hospital, well, all the community hospital sites except Lutterworth, and quite a number of patients are going to Colville. They can go across the borders. There's UHL, there's a walk-in service at Glenfield. So in the interim, while we're sorting out what we're doing, we're trying our best to then redistribute the patients, because it is actually quite a basic facility. We absolutely know that. And it's going to replace it is about £250,000, to be honest. And we're still trying to find out what a mobile could cost if we could even find where there is one, and we are searching significantly on this, and the West CCG are involved, they're helping. We've informed all the GPs and all the consultants who use Hinckley Hospital as well, and we've looked at, would that be a problem for a patient coming for either an outpatient or surgery, and where there are issues, we're looking at how do we move things around so that actually no patient is put at risk at all by this. So that's really where we are at this moment in time. We've got a meeting next week, which is the Alliance Leadership Board, where because the Alliance is basically the 3 CCGs, UHL, LPT, and then the provider arm, which is a bunch of GPs. So it's all of the parties. We've got that, and that's for discussion next week. And we're in conversations with the Director of Finance in the West, and he's trying to pursue NHS England, etc. So we're on board. Now to your next point, you're absolutely right. So what we're trying to do is look at, so traditionally the counties had the community hospitals, but actually the cities really just have the general, but they've got some excellent lift centre facilities. There's lots of stuff out there that have got rooms and availability. So that is as well, is part and parcel of what we're looking to do, is to actually say what can we put in what facilities and try and get it more multidisciplinary, because as you just said, you know, dietitian, etc. A lot of patients now, both old and young, do see a range of hospital doctors, and rather than dotting all over the place, what we're trying to do is say, can we actually get to you together? Because also it's, if we can get one form of the truth for a patient and not 6 different versions from different specialists on 6 different occasions and confuse the hell out of you, which quite often does happen, it will be a lot better. So part and parcel of this work is around doing that. So on the point of like trying to look at, so what is your workforce? So what we've been doing with dermatology, etc., is there is a number of GPs who have got what we call specialist interests. They used to be called gypsies at some point, but they're now GPers. So they're GPs with a special interest. It sounds funny when you try and talk about it. And what we do with them is they have to have a significant amount of training on top of their basic, so that they actually have become mini dermatology to a degree. They are then supported. So what I've done is I've got each of them have got a key mentor within the dermatology consultant workforce. We've built governance around what they do and how it's done. It's done to a set criteria of this is what they can see, and that's what we're working through with other specialties. And it's things like, even for ophthalmology, so what do we want our high street optoms? They're well trained. they've got lots of skills. We can enhance their skills to do more, so that actually the bath, as we think of it, actually isn't overflowing, is actually more manageable. So that's how we're trying to work. And actually, from your perspective, it would mean, so if we've got a dietitian who, you know, you're needed when you have your, they would be there, and you would get that support in that environment, and you would then get your whole picture and not have to keep having multiple outpatients, which again is not cost effective, it's not good for patients, and it actually costs more money because you're having to do more visits, and again your carbon neutrality because it's more zooming around.
Actually, my question was more about the restrictions on the outpatient list. So sorry, it's very personal, but it's, my daughter's dermatology nurse has got a clinic at the Royal and has got a clinic at Braunton Health and Social Care Centre. She can't book me on the Braunton Health and Social Care Centre, and that's the nonsense part of it.
Right.
Is she's not that she doesn't want to.
Why can't she?
Just there's the restriction because we're county patients.
Okay, I can take that. I'll take that back,
so
'cause that is
it's
silly.
it's that kind of. I'm hoping that these things are going to start to be being resolved.
So
that where outpatient appointments are available, the closest one to home is actually as important. Taking her out of school to go to the Royal when her school is 1.5 mile away from Braunton Health and Social Care Centre makes no sense to me. So
to
that's
be honest, these are myths, I have to say, and we need to dispel the myths because it doesn't matter, because actually people will know where you come from and you just actually then charge the relevant CCG, and it doesn't. But it's a myth, I think, that they've got, so we can take that forward.
Lovely, thank you.
Well done.
Thank you, Chair. I'm just reflecting, I've been an outpatient my entire life. And in that time, things like retail, even councils, everything's changed massively. Yet fundamentally, as an outpatient, it's exactly the same process it was when I was 6 months old. Okay, there has been some refinement and improvement, I'll admit, particularly in Leicestershire, mainly because of previous consultants, but fundamentally, the NHS hasn't changed its processes. I'm pleased to hear this because, you seem like you're in this dark ages compared to everybody else. And I just, I'd love to be able to do my appointments by Skype, but, because all I need is to have a blood test. Well, I have to trail to the Royal for a blood test. I can't do it at the GP, is a mystery. And, it's things like you're just talking about, why can't we do the bleeding obvious? I'm sorry, Chair.
We do still run outpatients very much like they did in Florrie's time, and we've got to get past that. But what we've done historically is we've tinkered around the edges, in honesty. We've never gone for a system-wide approach, and that's what we're going to have to do. Mainly because actually what we're doing is ludicrous for patients, and actually it's not cost effective either. So we do realise that this is what we've got to do. It's not a small task though, and there's a big cultural change because we have got quite a few consultants who are really on board with this, but if I'm being honest with you, it's not everybody. I've still got some sort of laggards who are kicking and screaming, but I'm good at dragging. That's one of my biggest strengths, and I know most of these young men since they really were young. So that is part and parcel of our programme. It is not going to happen overnight. This is going to take us a few years to really do, and we're going to have to tweak it. And we will have to, I think by specialty, it'll be an 80-20 rule. 80% we can do jointly, but there will have to be about 20% specific to the disease. And one of my goals is absolutely to see, as we're turning into, and I'm becoming one of them, a member of the public with a number of comorbidities, as they call it, diabetes and whatever. I don't want to be going for appointment here and appointment there. You want actually to see all of the people that are involved in your care in one place. And that's part and parcel of what we need to do, because that will make so much better. You'll get less duplication of tests and investigations. It's absolutely common sense.
I want to await the change with anticipation, Chair.
can I just add to that point? Just I've seen Helen drag a few people, so it's not a pleasant sight. However, what I would say, the workforce redesign that underpins this, and again, that's what we've put as one of our enabling work streams under this diagram. It's absolutely critical, as is the cultural change with staff and the public and patients. But it's also about people getting used to working in a different way and working from different sites. So as you've described, it's about making sure that there is that freedom of movement for our NHS staff across LLR, across the sectors, and that's a critical piece of getting this to work. We need to be able to move the workforce to where the need is the greatest.
Interesting. Councillor Mark.
Thank you for that, and thank you to Helen, especially for her 43 years dragging. It sounds like. I guess I've no fear about being radical, especially after 70 years, and clearly there are some things that need to change. I guess my fear is from kind of, I guess, the starting point of this, which, as much as we like to flower this up, there is an element where this is driven by saving money, and I guess that whilst that that there is a big thrust about that everywhere at the moment, I guess some of the terminology when I remembered that you were using kind of made me feel a bit uncomfortable. We talked about being braver, about patients looking after themselves, about virtual management, and somewhere in here it's talking about reassurance, and I was thinking about perhaps more vulnerable people who are also outpatients, right? I was thinking about lonely, frail, elderly, perhaps people with memory loss or the digitally excluded, for whom a lot of what we're talking about, however much of a culture shift we make, is not going to feel reassuring or comfortable to them. So I guess I'm looking to understand, is there any provision within this to ensure that people have the right to kind of choose, even if it is bonkers and miles away and, at the Royal when they live nowhere near, and multiple consultants, that they can still choose that for themselves within the plans here. Thank you. I'll turn mine off.
You're absolutely right. It will be different for different client groups, and there will be a need for face-to-face patient care for certain groups. But again, it's about a lot of the ladies and gentlemen you were just describing. They've got multiple problems, and actually it's about, really, you're the centre as a patient. That's how I've always worked. The centre is the patient. And so what do we need to do to wrap around a service that actually you can understand? Because that's the other thing. If you're bombarded with information from various locations, it's hard to understand what's next. Whereas actually if you're in the location and they're wrapped around you and they can actually agree and convey that to you and your relatives, it's a lot easier to then understand and plan what needs to be going forward. And with regards, yes, money, we'd be silly if I sat here and said money doesn't matter. However, I'm absolutely convinced 100% that actually we waste money by the way that we work. And actually this isn't about providing an inferior service to patients, it's about providing a better service to patients, and it will save money as a dropout, because you won't have all these wasted appointments, taking people here, there, one of the reasons that we closed Ashby from my perspective was anybody who needed an x-ray had to go to Colville to get it and then come back for another appointment, which is another reason why we need to sort out what we're doing at Hinckley quickly. Because it's wasted appointments and time, and that saves money as well as improves the patient's journey.
And if I can just add one further thing, maybe just linked to that. There's quite a lot of evidence in other areas. So, for instance, the paper talks about patient-initiated follow-ups. So there was a pilot that was done in Morecambe Bay for gastroenterology, which basically what they said was, these are the symptoms to look out for. If you have any problems, call this number. And that enabled those individuals to be able to contact the department when they had any particular problem. So, yes, they weren't seen formally in 3 months or 6 months, but they had that reassurance of being able to pick up the phone, speak to somebody and say, I'm feeling like this, is that right, what else do I need to do? And then the ability to have an appointment, an open access appointment, was available as part of that piece of work. And again, those are the types of areas and things that we're looking at doing.
So we're talking about Morecambe Bay, where there's a phone line. Have we got plans to put those in here? And I guess for those for whom virtual management of conditions is completely completely a misnomer, then you're telling me there is going to be provision available.
There is also some helplines already for irritable bowel syndrome and irritable bowel disease. They've got nurse-led helplines. Now, can they be improved? Absolutely. And that's what we've got to work through. You know, I mean, I'm very close to having a dietitian-led celiac disease service because they do it so much better than doctors. You know, doctors aren't the answer to everything, I can tell you that for nothing. And so it's about actually who is the best person to diagnose your disease. And a dietitian, we've got to use all of the skills that we possess within health and social care to actually do the right thing for the patient. So all of that is in our planning. And virtual clinics will take various guises. Some of it will be Skype. Some of it, I think, will be basic, simple questionnaires for post-op patients. The plan also is to say, because for a lot of patients, it's nervousness. Will I be all right when I leave here and I'm back at home? And so what we're going to do is say, right, you will get an ability to contact us within the next 6 months so that if this problem isn't going away and your GP hasn't sorted it, you can get back in quickly. That makes so much, benefit for patients because they go home feeling, well, if I have a problem, and I know that I'm not going to be left out on my own, not knowing what to do with that. So that, that's another thing that we'll be offering patients to actually, so that you don't get dragged back just to say, oh, that looks lovely, your wound's fine. And you think, I've waited 20 minutes in that queue, I've spent £5 and I've been sat out there for 2 hours and I got told off at work for asking to come here in the first place. We've got to get away from that.
Michael.
Thank you, Chair. Just really I really enjoyed reading a lot of the stuff that's in the paper because it really mirrors a lot of the conversations that people have about wanting to be able to get treatment and care nearer to where they live, given some of the problems that people face using bus services to go between services. So just making sure that where you are setting a hub, if you will, just making sure that that's got the necessary public transport around it. I think I was really pleased to not only hear that you're using the patient centre follow-ups because I'm actually a Sangronian, I'm from Morecambe Bay, so it's nice to hear it's actually doing something right for once rather than some of the other horror stories that's gone in the past. And there's, I suppose the only question I've got was around the, what's it called, the RSS, thank you very much. And just making sure that within that there is some mechanism for those patients who know they need to be referred, even if it flies in the face of what their practitioner is maybe saying, because patients know themselves better than anyone else, and there are times when that needs to be respected. And just is there a mechanism in that can respect that?
That's a very good point, actually, because being deadly honest, and I always am, there isn't actually. So I can actually take that back, because we're in the early stages of it, but there should be, because you're absolutely right, especially patients with long-term conditions, they know, I bully my GP and say, look, I need antibiotics, give me a set for when I can't get in a week on Thursday, whenever it is, and I'm half dead and need admitting. So it's about that, and I think we do need to build that in. That is a very good point, and I will take that back.
Thank you. I'm very supportive of the direction of travel in this paper, which is why I've not spoken earlier. But As people have been asking questions, something did occur to me. And I'll give you a personal scenario to illustrate. For the last, how old am I? For the last 45 years, I've been going on and off to Moorfields Eye Hospital. The condition that causes me most concern is a slowly developing one. And Moorfields regularly say to me, I'm not sure we need to keep seeing you because it's slowly developing. But I say, oh no, I want my appointment in a year's time. And the reason I say that is because if I don't, and suddenly there's a deterioration, which has happened in the past, I have to go and see my optician, then I have to see my GP to get another referral, and then they can't fit me in for 6 months, by which time I'm slightly getting a bit concerned about what's happening. I know my eyesight. I know when I'm struggling. I want to be able to ring them up and say, look, you've got me on record, I now need to come. Now, you've got no control of the Moorfields, clearly, but there will be other people with those sorts of scenarios, perhaps within ophthalmics, that are your responsibility. And it's not 6 months, it might be 2 years or 3 years down the line. But, you know, patients will go regularly every year unnecessarily just to make sure that in 2 or 3 years' time they can get the appointment. So it's just a thought for you.
And it's a really good thought, because actually glaucoma, AMD, that's exactly right. And the plan is, again, that you would give, and all long-term conditions, because loads of people, they're fine when they get their follow-up appointment, but actually 2 weeks after that, they then have a problem. So it's about giving them direct access so they can ring and get in when they know they've got a problem, because patients do know best on this front, because actually you live with it every day. So that is definitely part of what we would be looking at.
You did mention 6 months earlier, and I'm talking years later.
Yeah, no, and that's it for a number of patients. So for that's for post-op, but for long-term conditions, it would be for the rest of your life, because as you say, they're not going to disappear. You know, you'll have that till you're no longer here. So yes, that is part and parcel. Stops all this routine follow-up, which is possibly not very helpful.
Amanda.
Can I just ask a very small follow-up? Actually, following on from Councillor March's query earlier about those who were vulnerable. Obviously, individuals with, say, learning difficulties might be less able to communicate a concern, you know, recognise the symptoms. I'm hoping that they would still get routine appointments. That would be something that would actually just happen, and there would be certain groups that routine appointments would still take place.
Absolutely. The vulnerable groups you would actually, you know, I mean, are identified, and actually then you would look to say, you know, you would still continue to do face-to-face. But one of the things what we try to do is make sure that we get that's improved, because there is still an issue, and we do a lot of training, but we still need to continue to do more with our own staff on learning disabilities. You know, I mean, we've had a big lesson we've learnt in the Alliance around a learning disabilities issue that my staff didn't pick up properly, and actually the patient didn't suffer unnecessarily, but his experience could have been a lot better if my staff had been a bit more on the ball. And so we're learning that all the time. And it's same with like patients with dementia. You would do something different totally.
Really very helpful, actually. Thank you very much. It's heartening to think that maybe common sense is coming back to life. I mean, like you, I'm comorbid and all that lot. I've got, you know, things. I've got to go into a clinic on Thursday for armful of blood taken out, but you know, at least I now have the app. I can now follow things up. I'm into that. The test coming up, so you know, things are moving along. But still, thank you very much indeed. Very. Marie, it must be your turn officially. Yeah. So this is agenda item 9. We're nearly there. feel sorry for East Midlands Ambulance Service. So it's an update really on LPT, isn't it?
It is, yeah.
Thank you very much. After the CQC.
Thank you. So yes, I just introduced myself. My name's Anne-Marie Newham. I'm the new Director of Nursing AHPs and Quality. I actually started on the 1st of June this year. And also it was just to let you know that as well as the CQC update, there are some other changes around the Executive Board as well. So the purpose of the paper was to update members, and it was just to let you know that improvements that have been made as well. So we received our report in February of this year, and the inspection took place November, December last year. We were rated overall as requires improvement, but really disappointingly we got inadequate for the well-led domain. And well-led domain from a CQC perspective is around use of resources. It also includes things like supervision, money, funding, and how you best use your resources that you actually have. So on the back of that, the CQC also issued us a warning notice, and we received that on the 30th of January of this year. When you get a warning notice, you get a lot of scrutiny, you get a lot of intense pressure from lots of areas outside who require assurance on a huge scale. And so we've had to do fortnightly meetings with NHS Improvement, and also we've had to do monthly meetings with both NHSI and CCGs as an additional because of the ratings that we received. So the actions that have been taken in response to the CQC report, so this is on the bottom of your page 63. So this was about immediate improvement plans that we needed to put in place around 9 key areas. So they were access to treatment, privacy and dignity, environmental issues, care planning and risk assessments, fire safety, medicines management and medical devices, seclusion, environments and paperwork, physical health care and governance. And we also recognise that there are some longer term projects that we've put in place to drive those improvements as well. We have listed those in section 5, but I want to draw out the one around the buddy relationship with the executive mentoring with the neighbouring trust. Councillor Sangster actually asked me quite a few questions at the last Health Oversight Scrutiny Committee in relation to why Northampton. And so I just think that before anybody asks me the same question, I'll get it out now. And the reason Northampton is because there are only 3 outstanding trusts in the country from a mental health and a community perspective. And that is Northampton, Tees Esconweir and East London. And so NHS Improvement approached Northampton as it was the nearest one to us and asked them if they would buddy up with us. So the buddy arrangements were done pre the chief executive appointment. So it was agreed that we would be buddied up. A buddy arrangement is really interesting. I've been a buddy before in a previous trust to another organisation that was failing and in special measures. So the idea behind the buddy arrangement is that we would learn from an organisation that is currently outstanding, and outstanding in many ways as well. They also have, from a health perspective, and certainly in the Health Service Journal, Angela Hillary was voted one of the top chief executives in the country. So it wasn't just a willy-nilly, let's just choose them. There was a lot of thought that went into it. Also, it's a very similar trust. It has mental health services, learning disability services and community services as well. So the idea behind being able to work with some of their executives. So I'm working quite closely with my counterpart, Julie Shepherd, who's the Director of Nursing there. So we are working quite closely together. We meet on a monthly basis, and we go through things that I can sort of like use that they've got, so I don't have to reinvent the wheel. And I've used reports, I've used some of their templates, I've used some of their capacity. I've got some of their infection control people that have come over and done some reviews for me. I've got people coming over doing ligature reviews. So actually the whole Northamptonshire thing is benefiting us greatly. It's not capacity that we had or capability that we necessarily had either. So it's been of great benefit. I am I am an experienced director of nursing. I was a director of nursing in Lincolnshire for 3.5 years as well, in a similar trust, and a chief nurse in Derbyshire as well. I am a Leicestershire person. I'm actually from Rutland, and I used to work in Leicestershire as well, previously at LPT, so I have a good understanding of the area and what is needed. So the second point in that paragraph is about the joint appointment of the new chief executive. So post the buddy arrangement, we had gone out 3 times to recruit a chief executive, and there was nobody of any calibre that they felt they was able to take. And so they did actually go through with one set of interviews, and again, it was unsuccessful. And the second time they went out, they didn't get the calibre that applied, and the third time they didn't get the calibre that applied. So at this point, NHSI were getting quite desperate and felt it was important for us to have a chief exec, because our chief exec had already said he was going to retire. And it was important for us as an organisation to have somebody at the helm. So they approached Angela Hillary and asked if she would consider being a joint appointment, joint chief executive for Leicester Partnership Trust as well as Northamptonshire Foundation Trust as well. That was agreed, and she is now in post and has been in post for about 6 weeks now. And so far, it is going really, really well. And we are benefiting hugely from having an experienced, like I said, she's been a chief executive for about 6 years, and we are benefiting from having a very experienced chief exec. We've also sought a lot of external support. We've been down to East London, we've been up to Northumberland, Tyne and Wear, so we have been out to outstanding trusts to see how we can benefit from their insight, what they have done, how they've turned things around. If we look at Northampton, they used to be requires improvement 5 years ago, so they have turned it around, and actually sometimes we've benefited more from going to places that have been in special measures or been at requires improvement to see how they actually turned it around. So we've done a big piece of work around our staff. So the culture in the organisation, the culture and behaviours is a huge piece of work. We have undertaken a big piece of work that's called NHSI's improvement programme around culture and leadership. And in order to do that, we asked for volunteers, similarly to John Adler's presentation in respect of champions. And so we didn't expect to get so many champions, but we had 90 people come forward who said that they wanted to be a part of it. It was a choice that was made, and they were hugely supportive and said that they really wanted to get involved. So they conducted lots of focus groups, they interviewed the board, and they asked lots of questions, uncomfortable questions sometimes, but certainly asked a lot of questions to understand how does it feel to work in LPT. Because if we're inadequate for well-led, what are the staff feeling? What does it feel like to be on the receiving end of us as an executive team and as a board? So that's the piece of work that's being undertaken at the moment, is really digging into how does that feel. Some of the work has been done through SurveyMonkey, some of the work has been done through face-to-face, focus groups. It's been done in lots and lots of different ways. It's been gathered, lots of information. So there's over 2,000 pieces of information that have been gathered so far, and they're doing the synthesis of that information to say what are the overarching kind of like themes that are starting to come out of that. We've also sought advice and support from the national res team, so they came down and gave us advice of how we could better meet the diversity of the population through the diversity of our own staff. And so that has been a big piece of work that we've been doing as well. We recognise that we've not been great at doing patient involvement. We do lots of consultation, but we don't do true co-design. And we consult and consult and consult, and we send out lots of things, but really that's not actually getting what people want and what people say. So we have really turned that on its head. We've changed it enormously, and we are getting lots of advice from external expert by experience patients and members that are telling us and helping us to understand what true engagement really is. And the board have also received a very hard-hitting presentation from some experts by experience to say this is how it feels. And like I said, uncomfortable, but absolutely worthwhile, really good. The board have taken it on board, what they need to do. I also then wanted to say that because of the enormity of what needed to change, and there was a lot, we've had to do it in a three-stage approach. So talking at number 6 here, the three phased approach is, phase 1 was get on and just do the immediate things that needed to be done, like your fixtures, your fittings, your painting, your decorating, you know, some of the really quick wins. You have got to do it, get on and just do it. The second one is very much around the quality improvement work, which takes a bit longer to do that. So that's really applying a methodology of improvement. So this is your problem, this is what we apply to it, and this is the outcome. And the third one is much more around the sustainability of it all. You know, it's all well and good putting lots of things in place, but actually if you go back to it, it hasn't really sort of like been sustained. People don't continue with it, and people lose interest. So that's our 3-year quality improvement plan. So on the back of the inspection and the report, we were required to meet a lot of people, like I said, and on the 5th of June, we had a room full of people that were interested in telling us how they wanted it, and that included NHS England, NHSI at the time, CCGs, Health Education England, and many other people. And at that point, what they were primarily worried about and concerned about were neurodevelopmental weights, the environment still at the Bradgate unit, demand and capacity, balancing the prioritisation of work within the trust with the wider STP network, developing the right culture, and this has then led to further stakeholder meetings that we've been involved in. We've also received advice and support from NHSI, so they've sent us in a turnaround director who's been supporting us with our governance and our corporate governance that was poor. So we had an unannounced inspection in June, and they came beginning of the 10th of June. They came from the 11th and 12th of June and then reported back on the 13th of June. That was then published on the 9th of August. It doesn't change our scores. They can't do that. When they're doing an unannounced after a warning notice, they can't change our scores that are publicly published. So it stays the same, but what they have said to us is this is what they said. So this is what they have actually said in the paper, and this is what is published. They were very impressed with the environment. They said that it was remarkably different to when they'd first come. They couldn't get over the difference. They also couldn't get over the difference about how staff were, because when they came in November, December, they felt that staff were afraid of them. But when they came this time, staff wanted to talk to them. Staff kept saying to them, come and have a look at this. Come and see what we've done with this. It was a very different approach this June. So you can see the significant improvements that have been made there on number 8. However, number 9 shows that there are still areas for improvement, and that is around the environment still. So that is around capital. At the Bradgate unit, we still have dormitories, and dormitories are just something that we just should not have. I don't know how else to put it. And by March 2020, the CQC require a plan that is very clear about how you get rid of all your dormitories and you have single accommodation. Our counterpart in Northampton have everything as a single accommodation. They have no dormitories whatsoever. We are about 3rd in the country for beds in dormitories. So it is a really poor area to be in. And actually patients say it feels unsafe, they don't like it, they've got somebody next to them that's unwell. And this is an area that I think we absolutely need some support on. The CCG, we have applied several times for capital funding. We're on wave 5 and we're going to try again, but each time mental health and community trusts don't always get a good look in when it comes to the acute trusts, because they often take priority. So the continued improvements are required, and that is around our maintenance, our estate, also the further rollout of our medicines administration technicians. They loved that, but they wanted more of it. They wanted the rollout of smoke-free wards. Smoke-free is really difficult in mental health. It's one of the hardest things. I have to say, I'm not 45 years, I'm 37 years. 37 years in the NHS. I've worked in every kind of healthcare setting, but mental health is so hard to stop people from smoking. So smoke-free is what we're tackling. When the CQC came, they found cigarette butts and they didn't like it. But we have a big programme of offering vapes, a big programme of offering smoke-free. We've got a fantastic service in Leicestershire that actually is quite unusual across the country for smoke-free support. So we're making use of all of that, but it's still not there. And also, they pointed out our seclusion paperwork. Whilst we do seclusion very well, they are not impressed with our paperwork. It's very long, it's about 16 pages. There's a lot of legality around seclusion. It's not something that you want to do to patients. We're certainly reducing it. We have less seclusion rooms, but when we do seclude, the paperwork needs to be improved. And also then the long waiting list for our CAMHS patients. We have really, really good, we've done some very, very good work on CAMHS waits, but what we're not good at is we see them very early, but it's the next wait after that. So we see them for the assessment, but then they have to wait a long time to go to where they have the speciality or the next bit. So they'll get their assessment and they'll get, right, this is what's needed, but it's the next bit that takes too long. And then I talked about quality improvement. There was a long conversation from John Adler about quality improvement. Quality improvement's the way forward. It's the only way that we're going to be able to deliver some of our improvements over a long period of time with that sustainability. Our approach to quality improvement is through something called Step Up to Great Priorities, and we have 9 of those. And they include transformation, buildings, estate, standards. What do you walk past? What do you stop seeing? One of the big pieces of work that I've brought in at the moment as Director of Nursing is we kind of like get used to things, and we start walking past stuff. And what we've got to say is, I'm starting to say to staff, is be more curious. You know, if you see something, you know, call it out. Don't just accept it. And that's back to the standards that we've got to improve on. I did include some slides, but that was just more around pointing out some bits and pieces around improvements.
Thanks very much. I don't have to declare it as interest because I've retired from the NHS, but for the last 14 years I've worked at Northampton General Hospital, and I have worked with NHFT very closely, and I've saw huge improvements. And I have to say, I used to go back home, I live in Leicestershire, and I used to think, why can't we have that in Leicestershire?
Yeah. Maybe we will now.
Sarah.
Thank you, Kevin. In fact, I suspect I'm the longest serving on this county health committee, and we've had many times LPT have trotted in after a poor CQC, particularly around the Bradgate unit, and we have this, that's, and the other's going to happen, and it happens for a bit, and then it falls down on its nose, and then you get another bad, and it's like some sort of horrible repetition. I sincerely hope that you can turn the corner with this and actually deliver the changes. I'm pleased to say in the next presentation, EMAS have done it, and fair play to them, and I'm pleased for that. But I'm just very jaundiced about PT, particularly as on the other side of the coin, we've heard earlier about the community health redesign. Absolutely. And there's lack of management capacity for you to deliver it. So, you know, you've got 2 balls in the air in completely, 3 if you include CAMHS, with 3 very different disciplines. You know, making that work. So I'm assuming Chair will continue to keep an eye on this, but I'm, you know, been there, done that, got the badge and the T-shirt too many times, unfortunately.
Quite. Amanda.
Yeah, I mean, I've been involved in this for a little while as well now, and I think that you does feel a little bit like Groundhog Day. Actually, it doesn't now, and it's been quite different today. I felt quite a different vibe about it. But actually, also added to the gentleman that came to our last county health scrutiny from the transformation team, I think we took comfort from that as well. Can I just raise it, just a small point? I'm really impressed that you've stayed the whole meeting. And I think one of the things that's really interesting, particularly as you sit here as councillors, we sit and see the whole lot. And the interconnectivity between all of the papers that we've had today, I'm sure you'll have seen, and it's been sparking all the way along. And I'm really pleased.
I've decided now I'm not coming with Tamsin again, because every time I sit near Tamsin, I end up getting some questions as well. But yeah,
but I think that's really positive that we're, you know, that people commit to staying the whole time from health colleagues. So thank you for that. I suppose the only thing really is that the medicine administration has come up over and over again in repeated CQC inspections. Now I know some work has been done and there's been some recruitment. Are you confident that those, you know, real basic bits, I know we can't solve the infrastructure overnight, but actually we can solve the medicines, we can make sure that they're in date and that kind of stuff. Are you comfortable and confident that the Bradgate unit, that we are going to reach those things?
I've come from, so I came from a trust that I turned around from requires improvement to good, and I turned around requires improvement to outstanding for well led. And so one of the reasons I was recruited was because they felt that I could do the same here. Okay, so there's a lot of there's a lot of confidence in me as an individual, and that feels very weighty. I can't deny it. That feels like a huge weight on my shoulders. And and NHSI have said only in the last 3 weeks that they were going to give us red again, but have decided to give us amber just purely on the back of me being appointed. And they've written that in their report, the fact that they feel that this can be turned around. Now, I'm going to say something. I love the idea of people being empowered. I absolutely love it. But I think where LPT may have made a mistake in the past is something called self-regulation, where they've allowed people just to say, yes, we've done it, without very, very little, show me the evidence, show me the evidence. I'm of a different ilk. I want to know the evidence. I still empower. I still believe that people are good at their job. We pay people a lot of money. They need to get on with it and do it. And so I believe that we've gone too far with the self-regulation. So back to your medicines management, you know, I have still found things that are out of date. I have, but that's me finding it, and I'm saying, you know, that's what you can't do. So we're bringing in a scheme called ward accreditation. And ward accreditation is really clear. You have got to tick these things before you can move on to the next stage. And that's what we're bringing in. So we're bringing in a really different style. No more self-regulation, no more kind of like, yeah, we've just done it, show me that you've done it. And I suppose that's the only way I can assure you that we're on it.
Thank you. Like colleagues, I have been very concerned about the CQC reports we've had on you. I was particularly scathing last time about the overall governance of the trust. I am pleased that some of the progress that's been made. Like colleagues, though, I do have concerns about sustainability and would echo that we need to have it back again. We can't let this just go away because there seem to be improvements, and Northamptonshire are super. But I have a very specific question, and that is, while you still have the physical Bradgate unit, how realistic are your improvement plans given the shortcomings of the place?
Yeah, great question. So, a great question because I've got an answer for it. So as you are aware, at the Bradgate, there's about 7 wards. Opposite, so in between the County Hall and Bradgate unit, there's a big piece of land, and we're currently building on there the brand new CAMS unit. So that is a fabulous brand new build for CAMS, because currently they're out a long way away to really sat in isolation. Okay, so what we're doing is we're building in this area. So the next thing that's happened, as well as that big build, we've now put a strategic outline case for the Bradgate unit itself. So that is about, but there's some hard decisions to be made there. So what some areas have done across the country, and this is a hard ask, is you reduce your beds. So you reduce your beds in order to not have so many dormitories. And that is the conversation we're currently having with commissioners. But there is currently a strategic outline case that has gone in to improve the build at Bradgate. And it's not about tweaking, because I agree, a little bit of refurbishment here and there is never going to do it. It's going to take taking the bricks down and rebuilding them. And that is what's gone in at the moment.
Michael.
Thank you, Chair. I think there's quite a few things that I've heard you say in various different meetings, which to me is kind of music to my ears. I think there's I've kind of seen LPT over not as kind of long as some of the members, but nearly the last 10 years. And what seems to be when things really started to go wrong was when the senior management team in LPT stopped listening and stopped engaging. And you kind of saw that being really kind of played out by the kind of the rapid turnover of their engagement and their complaints team, which was tiny considering the size of your trust. So some of the actions around your patient representatives, the kind of experts by experience, really kind of shows to me that you want to start that conversation. So it's just a plea to make sure that never stops, no matter how difficult it gets, because you're going to get a kick in, I think, for a little while, because LPT has got a legacy of not listening. So now that you've opened your ears again, which, well done, people are going to have a lot to get off the chest. So, it's going to be tough, but it's going to get better. You've been really kind of inclusive of our board member Mark with a lot of those conversations.
I've got great shoulders. I'm very experienced, like I said. I got an MBE this year for services to nursing. I'm not going anywhere. I'm a Leicestershire person. I'm in it for the long haul. I want to make a difference. And I have some fantastic executive colleagues. We've got a new medical director, a new finance director, a new chief executive. She has just brought in a director purely for mental health to sort out the Bradgate unit. He is very experienced. He's a mental health nurse by background. He starts next week, and he's been a director of mental health for many years. We have huge optimism around what can be achieved. So thank you very much.
It's not really a question, but it's just really a comment. It's really reassuring to help that, because from a young child, I've been in and out, not myself, but with a family member, and I've been in that unit 2.5 years ago, and it was really shocking to see some of the things in there. And the family member goes in and out quite often. So that's quite reassuring, not just as a counsellor, but as a family member to somebody what uses that unit, that there's somebody like you, as well as the rest of the board, acting.
Thank you so much. That's very kind. Thank you.
No, I agree. I think it's reassuring, but as colleagues have said, proof is in the pudding.
A lot of work to do.
We've been there sort of before, although not. I don't think
I
with
agree.
so much evidence. I think particularly the changes in the leadership has. I hope that will be. It will come up. I'm sure it will. We'll see some great improvements. So we'll follow it through with you as time goes by, and hopefully it'll.
I'd be happy to come back.
Yeah, no, that's lovely. Thanks.
I'm going to stay with my EMAS colleagues. Yeah. I used to commission EMAS.
Lovely. Thank you, everyone. If I just start by introducing myself. So I'm Russ Smalley, the Service Delivery Manager for East Midlands Ambulance Service, just for Leicestershire. And I've certainly also endeavoured to be a relatively functional paramedic when the day job allows. So I'm here today with, I think, two, on the grand scheme of things, relatively good news stories, I'm pleased to say. And that's, first of all, I'm going to touch on our most recent CQC result, and then just build that into our big three, which I believe we certainly had representation here before to discuss our big three. I think certainly now on the back of the CQC report, we're certainly in a position to really start moving forward with that and actually changing the direction of the organisation. So I just want to give you an update in relation to where we are with that, and I think our next significant change around our clinical model and how that will hopefully benefit the system as a whole and the patients that we serve within it. So, you know, I'm very privileged to be able to sit here and tell you all at our most recent CQC review, which occurred over April and May of this year, we got an overall rating of good. I think in particular we was recognised to be outstanding for caring, something that as an organisation we're exceptionally proud of. Again, also recognising that across the country there's only a handful of ambulance trusts that have been recognised as outstanding within that domain. I think even more significantly, I think it reflects a real journey that as an organisation we've been on, certainly probably the last 2, 3, 4, probably 5 years actually, a journey of improvement. So 2 years ago was recognised as requiring improvement, and that's the position that we've ultimately ended up in. The next graphic I think really just demonstrates those CQC domains and the improvements that we've made based on the last review 2 years ago. So with the exception of patient transport services and resilience, which wasn't previously reviewed, as you will see, for the best part we've improved in most of the domains, and if not maintained the good result previously. Again, I think most significantly that I just wanted to touch on is 2016 we was noted to be inadequate in SAFE. So again, a real step change within the organisation to get us to this point. And again, the outstanding for caring for emergency and urgent care, which again we're all particularly pleased of. Within that report also recognises several areas of outstanding practice. One of those areas is particular to LLR, and for us that's in the development of dementia-friendly ambulances. So a UK first. Certainly already getting national acclaim and international acclaim for what this is set to do. And actually I think it's not too strong a word to say this will revolutionise the care for dementia patients. Absolutely recognising that there are a significant cohort within our day-to-day workload. So what that typically looks like in this first phase is the design and environment of ambulances. So we've got the example of the pitch here. So this is just what would ordinarily be a window within that ambulance is this design feature now. So intended to distract, to create conversation, to engage with that individual. We've also got the implementation of twiddle muffs. So for anyone familiar with these are essentially what it looks like. It's a device, if you like, for the patient to be able to place their hands in that's got lots of different features in there to distract them, I think be a conversational topic, and hopefully make that patient experience during that journey far more amenable than it perhaps currently is. The third element of that is the utilisation and provision of music. So each of these ambulances will have a USB that will have a full body of available music identified by decade, to hopefully allow us to play music relevant to that individual, again with a view of making that patient experience far more enjoyable for them. That's where we are in terms of the first phase in relation to that. Certainly by the end of October, every one of our ambulances in Leicestershire will be dementia friendly, so the best part of 60 traditional ambulances. And we are currently running the pilot for the trust, but again I think there's absolutely a lot of focus and a real drive around an implementation trust-wide, recognising the benefits that this will serve for patients. This isn't being done without foresight. You know, as part of this piece of work, we've engaged closely with the University of Northampton. They have a specific dementia group down there, Unity DEM. As part of that, we've engaged with service users, the relevant multidisciplinary professionals, be that professors specialising in dementia, and therapists also. As part of that piece of work, there will be an end of pilot review, and that's going to be supported by our internal research team. We'll be looking at the qualitative elements of this piece of work and how that can be enhanced and developed moving forward. So all in all, we're in the very early phases of this, but I think a really exciting development And again, I think on the back of that CQC report, the organisation more than ever now is in a great position to really drive forward the care that we are providing on a day-to-day basis. The CQC report did also highlight 25 should-dos. I think most significantly, we have no must-dos. Of those 25 should-dos, all achievable, all absolutely within our gift to take on board and to start developing furthermore over the next 12 months. The next steps have already been initiated, so I think that's been the identification of those should-dos and implementation of improvement action plans across all areas, and they're trust-wide. So that's it from a CQC perspective in terms of that overview that I just wanted to give. And I just want to spend a few minutes talking about our big three, the trust vision, and I think particularly now how that CQC report gives us the opportunity to really drive that vision moving forward. One of the key elements I just wanted to touch on today was around our clinical model, and actually what the benefits potentially our revised clinical model is going to give for the system as a whole. So here you'll see our current clinical operating model and the three strands to that, all three strands that we see as being key developmental areas to drive this organisation forward over the next 3 to 5 years. What I want to touch on today is the right response to the right patient, and specifically now the introduction of specialist and advanced practice roles within our organisation. So here we have quite a busy slide, so bear with me and I'll just give us a succinct overview. So what that essentially demonstrates is our demand and where our demand comes from, how we split that demand and how we look to serve that demand. Our current mode of operating is very traditional ambulance. So we have three strands of response, if you like. We have our fast response car, which is typically manned by a paramedic, and our double crewed ambulances, our traditional ambulance, which will have a clinician on board, not always a paramedic, but certainly a clinician. And then the final tier of that is our urgent care ambulance, and they typically do our GP admissions, our urgent admissions. So what we see there is a very traditional ambulance model. For the best part, and certainly for the last several decades, it's been an effective model. I think more than ever now the system is changing, the demand within the system is significantly changing. And in line with that, I think we recognise that our ability to manage that demand and impact on that demand within the system has to change. The first phase of that for us is the implementation of specialist and advanced roles. So there we have, in terms of the blue sections being our traditional model, and the implementation of our specialist roles identified by the red and green sections. So that's going to look in two different elements to that really. So first of all, the developmentation of an advanced paramedic role. Notably, that will be targeted towards our Category 2 calls. These will be advanced clinicians, holistic clinicians, with the ability and increased scope of practice to deal with those life-threatening emergencies. And then also the inclusion of specialist paramedics. So specialist paramedics will focus on individual areas, and for example, mental health will almost certainly be a key facet of that specialist role. We may find maternity, frailty, dementia equally. And they will be targeted specifically at those patient groups. Significantly, and if you look nationally around what advanced and specialist roles can bring to a system, is what we know is that these clinicians with the increased scope of practice typically non-convey, don't take their patient anywhere about 70% of the time. So if we think about what that looks like for our current mode of operation, we convey about, on average, 55% of patients, 55% of patients a month. So we're potentially going to allow that demand to be managed far more effectively for the benefit of the system, circa 15 to 20% of the patients that we're going to see. I think it goes without saying, I think this delivers an awful lot beyond that of just demand management. These patients will have a better outcome. They will almost certainly have a better experience. It will allow us to manage demand more effectively, and that can only be a benefit to this system in particular, where we know that currently we have lots of demand pressures and lots of challenges with managing that demand. And that's where we are in relation to that. So very much at the point now of the advanced and specialist roles going to Trust Board, with a view to piloting that in Q3 and early Q3 heading into next year. And that's all from me in terms of that, I guess, whistle-stop tour of that CQC report and the next stages of our clinical model. And so open to any questions.
Thank you very much, Russ. Very helpful.
Thank you, Chair. Just a quick question, really, about something that kind of living in Leicester City and kind of driving around the county quite a lot. It's sometimes concerning about how many non-EMAS ambulances there tend to be around and what's kind of happening around kind of resource and trying to build up the workforce.
Yeah, so I think very good observation. That's absolutely the case. So what we've seen, particularly in Leicestershire, but as a trust, and we've known for some time, certainly over the last 2 to 3 years, is that we've had a significant workforce gap. And that has been secondary to the funding and the commissioning of our service in terms of the output that we've been able to provide. So as part of the last 2 years of commissioning, reviewing our workforce, that's absolutely recognised that we had a significant workforce gap in terms of where we need to be able to deliver the national standards. So we currently have a very active workforce and recruitment drive. We're 18 months into that now. Leicestershire has seen an increase of circa 50 to 60 staff, but we've still got some way to go. So we're still probably 50 staff short of where we want to be. And we have a workforce plan across the course of this year to get us to that position. Whilst we've got the workforce gap, we need the support of those private provision to allow us to get to patients in a timely manner.
Sarah.
Thank you, Chair. I mean, EMAS has been one of the problem child in the past, and it's great to see. I'm really pleased, and hearty congratulations. It's been turned around, and not only that, there's good ideas coming for the future. I'd agree with about your workforce issue. I did a shift a few years back, and it was clear that the problem wasn't the staff or anything else. It was the fact you haven't got enough of them on the ground. So you're heading the right way. And don't knock the private guys, because when my husband went to the hospital the final time, they were fantastic. They were ex-NHS working for somebody else. And to be honest, given the pressures you've had, I can see why you use them. And I'm keep recruiting. And the new model, I suspect part of what you can see from that is because you free staff up from being double crewed and being expensive ambulances, you're able to get more bang for your buck, which I think is great. But I'm pleased with CQC. I mean, well done. There's been a lot of work gone into that, I suspect, to turn it around. So thank you.
I think you're absolutely right in relation to the workforce. I think we recognise, the NHS recognises actually that the workforce is a real challenge, certainly for us organisationally and particularly within Leicestershire and Rutland, it's a challenge. That's not through want of trying or not through want of having available money to recruit those staff, so much so that we currently have an active recruitment campaign in Australia. What nationally, paramedics are a sought after resource, and certainly now with the development of the primary care networks, it's a risk for us. It's absolutely a risk for us. So something we're very cognizant of. The Australian opportunity is absolutely that, a real opportunity. We're certainly not the first ambulance trust within this country to exploit it, for want of a better word. Certainly London takes circa 200 to 300 Australian paramedics a year. We're only just dipping our toe in the water. So currently in Leicestershire we have 5. And that was from a recruitment of 8, so they've just joined us. A fantastic addition to the workforce that we have. We're currently out for advert again, and we've at this moment in time have 15 in the pipeline. So again, I think I just wanted to make the point around we recognise the workforce challenge. It's easier said than done. It's not as simple as going out there and recruiting from what is becoming a very limited pool of staff now. So we hope over the next month, certainly linking into Australia, we can start bridging that gap and actually reducing the utilisation of that private provision.
West London Health Trust are doing a 1-year master's conversion for existing NHS staff, because a friend of mine's daughter's done it who's an OT, and they come out of it with a paramedic's job. And it's a mixture of classroom and on the job, and that's a sneaky way of doing it, actually.
Yeah, I think a further point to that as well is around particularly looking at our revised clinical model moving forward over the next 12 months. So we talk about advanced paramedics and specialist paramedics. However, there's nothing to say that actually we won't start to explore other healthcare professionals and those allied professions that can actually support us with our demand management and actually provide more holistic care in the community working for ourselves. So I think absolutely.
Councillor March.
Thank you. Unlike my county colleague, of course, I do have deep reservations about the use of private companies generally anywhere in the NHS and in our emergency kind of ambulance provision, I guess, especially. I'm interested to understand, are we, in terms of remunerating those companies, I guess that's costing us more than if they were our own staff, hence the recruitment drive. And I'm also, and so perhaps some figures and information about that would be at a later date quite helpful. And I guess I'm also interested to understand, whilst I understand the pressing problem of the current shortage of staff, is there not something we could do, as she suggested, in terms of developing people ourselves, maybe, I don't know, kind of routes from kind of leaving college through university, that sort of thing, locally with our own young people within our existing population, rather than going literally to the other side of the world to find people to do that for us. Thank you.
So I think your first point with regards to the private provision and cost, it clearly does come with a cost. I'm not going to sit here and take numbers off my head, but I think typically speaking that costs us more money than it would be to have our own staff. I think that goes without saying, but we can certainly note it and bring it back for a future point in terms of where that money is being spent and how that money is being spent. Absolutely take the point with regards to local development, local utilisation of people, as opposed to the around the world trip to recruit. So we're heavily involved in the emergency services cadets now. We've previously been a missing piece of that blue light work. So I think we're starting very young. We're starting to link in there to make the most of those opportunities that do come about. And again, we absolutely have internal workforce pipelines where we are developing our own staff. So we have internal now. So if I just very quickly touch upon our roles that we have. So we have assistants, if you like, emergency care assistants. We have ambulance technicians who are absolutely clinicians, but not registered clinicians, i.e. a noted health professional. And paramedics, typically speaking. So certainly internally, currently, we have routes for both our emergency care assistants and technicians to develop into paramedics, of those robust links with universities to support that.
Amanda, then.
Just to echo what Sarah's already said, I mean, it has been something that you see reports over and over again that the service isn't doing as well as it could do. To see something that's as positive as been put in is really encouraging. I think one of the things that's actually what's quite nice is the innovation that's come out of that as well. Is it's not just about service improvement because we have to, because CQC said we had to. It's actually the over and above, the innovation that's come through. I imagine dementia-friendly ambulances also would come. A child with autism would also have other calming effects. Actually, being in the back of an ambulance for anybody is not a nice experience. So anything that makes that more comfortable and easier for the patient has got to have other benefits. So I think it's really encouraging, and it's really great to hear the improvements that have been made, and it certainly is a very different experience from a couple of years ago. So thanks for all the work. We do appreciate it.
Thank you. I'd also like to echo Sarah and others. It is much relief to see how much improvement there has been in this service. It's caused us some angst here and within my own authority of Rutland on a number of occasions. I have an observation and a general question about the dementia-friendly ambulances, and then a couple of other questions, so I'll just go through the whole lot. The observation about the dementia friendly, I hope the music or radio or whatever can be turned off, because personally I don't think anything would encourage me to have a heart attack more than a whole load of music playing when I'm feeling stressed anyway. But the question about it is, you talk about Leicestershire. If you live anywhere within Leicestershire, Leicester or Rutland, would you be guaranteed to get one of these ambulances, given that your service covers a much wider area? That's that question. My second question is, how much of this improvement is down to the increased funding that you got at the end of last year, I think it was? And my third question is, will this improvement be sustained during the winter months and all the winter pressures that we get? Thank you.
I will certainly endeavour to remember every one of those questions. So, the first one, so it's interesting with regards to the music, and I think some of the social media feedback that we've had, and actually that's been a relatively consistent theme actually around the risk of forcing people to listen to music. And I think we are very explicitly clear that'll be absolutely tailored to the individual, and we're not going to play music for the point of playing music. And I think, so interestingly, and one of the wider pieces of work in relation to this is the development of dementia champions within our trust. And they're going to be targeted with additional skills to recognise emotional states and to support with some of that decision making into the utilisation of the twiddle muffs, into the utilisation of the music. So yeah, I think I'm absolutely assured that this is going to be patient-centred individual decision making, as opposed to an holistic blanket, everyone gets this. Certainly, and in relation to your question with regards to guaranteeing or the likelihood of these ambulances being available across the whole of LLR, I think certainly by the end of October, we expect every traditional ambulance to be dementia friendly. So I would suspect it's highly likely that wherever you are within Leicester, Leicestershire or Rutland, you will likely get a dementia friendly ambulance. And I think the key thing for me to touch on this is that this will be an ever evolving and developing process. So we talk about the environment of an ambulance. So there's lots of features of an ambulance that we recognise we could change to make more dementia friendly. We've started off with the window pattern. So that's going to be the baseline delivery, if you like, of those dementia friendly ambulances, but certainly something that's going to evolve over the course of time. Sorry, your third question.
Thank you for answering those two. My third one is, how much of the improvement is down to increased resource?
Yeah. And by resource, money. So I think, absolutely what we have to recognise as an organisation is, I think more than ever, certainly for probably the last 10 years, we have a solid foundation. And that solid foundation, I think there's several facets to that. I think for the first time in a long time, we have a substantive executive board. We have a substantive chief executive. Having the consistency in that leadership, I think, has gone an awful long way to driving those improvements. I think, again, without a shadow of a doubt, having increased funding has allowed us to achieve a financial stability, and that financial stability is providing, again, the framework to develop and improve. And let's not withstand, the majority of that increased funding has gone directly to our workforce and is increasing our workforce numbers. And without a shadow of a doubt, I think it goes without saying, with an increased workforce, we'll be more effective at managing our demand. If we're more effective at managing our demand, we're going to allow additional capacity to make the improvements that we want to improve and where we need to improve to drive the organisation forward. Where I think historically, the majority of our time has probably been spent firefighting, and we've now got the capacity and resource to drive those improvements. and to keep driving the organisation forward. I think I absolutely recognise and wholeheartedly appreciate the recognition I think several of you have given today. I think internally, I think we recognise that it's something to be proud of, but I think the internal message currently is that we've still got an awful long way to go. I think we've just achieved good. I think now the challenge is sustaining the good and driving the outstanding. So we're only at the start of that journey, but I think more than ever now we've got the foundation to move on.
It's encouraging, isn't it? And as Sarah said, we've sat here for so many years with CQC reports from the EMAS and from LPT, and it's just, but it really is, it's great. Amanda's pinched the point I was going to make, but I'll still make it. I've actually been involved with a autism initiative in my area for the last couple of months, and much more aware now of having met an awful lot of people of all ages with autism, some of the constraints that just everyday living, everything I take absolutely for granted, and light, they can be dimmed. It helps sometimes. Music certainly, and so in a way, it may well be, without doing virtually anything else at all, you could call that dementia and autism friendly. So I think that would be worthwhile. It's strange, but anyway, great. No, good news, and hopefully it'll continue, and we'll look forward to hearing about it in the future. Thanks very much. Right, everybody, we've come almost to the end of this list. The final bit on the point is that the next joint meeting is actually on the 24th of January at 10 o'clock again. Well, it will be in this room. It's just one of those things, the way that the diary's gone, but in fact tomorrow our Health and Overview Scrutiny Committee for the county meets as well. So I suspect some of those papers will be back again. But thank you very much from the city. Nice to see you all. One or two of you we've met before, but some new faces. Nice to see you. And thanks, Russ. That was really good. Thanks. Just in time for a bit of lunch, maybe. Might just scrape that.
These minutes.
Yeah, I'll signature them. Good stuff. Yeah, quite. Mad, isn't it?